The password for that meeting, we're going to start having password protection on all our future meetings. So I believe, Hisham, you can correct me if I'm wrong, we are going to keep the password the same for all meetings?
That's correct.
Okay, and it'll be Amity20, so that's A-M-I-T-Y, all capitals, and the number 2 and the number 0. So Amity20. For all our additional talks coming down the pipeline, you can obviously see the emails that we're sending out, and also go to dtacademy.ca/webinars. So dtacademy.ca/webinars. Every time you attend a webinar, however, you will be added to our email list, and you will continue to receive emails now and throughout the year. Now, do you have, we also have Vic Jindal, my brother, for those of you that don't know. He's going to be doing a talk next Monday with, in partnership with Dental Implant Surgery. It's going to be on the financial side of dentistry. The topic of that seminar is this the death of dentistry? And I'll give you the answer. No, it's not. But he'll give you a lot more details. So he did a little teaser seminar that many of you attended about a week ago, but this is going to go into a lot more details and numbers. And so it's definitely one I think we should all attend. It will help give us direction and peace of mind as we move forward.
And I've just put the, sorry to interrupt, Manisha, but I've just put the link online. I'll put it up again. And this is the teaser video that Manisha is talking about. I'm just putting it up on the chat group right now.
And his talk, this talk coming up, his previous talk, and a bunch of other awesome dentists speaking, including Azim Sheikh, who'll be speaking right now to us. All of their talks are on the Dentistry Disrupted YouTube channel, so you can check out all of our talks moving forward. Will all be uploaded there. For some housekeeping, every time you attend these Zoom webinars, you will get CE credits for that. 1 or 2 category 2 credits when it is a clinical discussion. When it's something like Vic's discussion on finances or practice management or anything like that, it's category 3, and it'll be based on the number of hours of the presentation. For all the previous ones everyone's attended, we are going to get those out for sure this week, likely in the next day or 2, so stay tuned, you will get that. Remember that you must write your email, your full name, your email in the chat in order to receive that CE. I'm going to email out the CE to everyone, but if the college audits us and asks us like who attended, we can only reliably do it based on the chat, because we can actually print out the chat. Many of you have emailed me afterwards saying, hey, I forgot to do that. No problem, I'll add you to the list, but it's not on the official registry, so kind of use at own risk in that scenario. So please remember to just do it right now before you move on, and we'll get those all emailed out shortly. We'll ask you to please mute your audio and turn off your video if you haven't already in preparation for our talk. Any questions you have, you can go ahead and type them into the chat. We will address all those questions at the end, or as if we can get to all of them, because we do have a lot of participants today. We have 350 people approximately registered. So we're going to continue to have more people join on, I think, in the next few minutes. And I think that covers everything for now. At the end, we'll go over these instructions again in case you missed anything. And now I'd love for Hisham to introduce our awesome speaker for today, good friend, Dr. Azim Sheikh.
Awesome. Thank you so much, Manisha. That was incredible. A couple of additional things real quick. All of our upcoming talks will be at 12 p.m. from today all the way to Friday and Tuesday. However, Vic Jindal's talks are going to be, he's going to have 2 talks on the same day. One is going to be at 10 a.m. on Monday, April 20th. The other one will be at 2 p.m. on the very same day. So we're looking forward to having you guys there. So I'd like to introduce to you guys the one and only Dr. Azim Sheikh. And I'll tell you guys my honest and personal opinion about Azim. I've met Azim now a couple of months ago at the Dentistry Disrupted talk. And, you know, we got to know each other quite well over the last couple of months. And I have to say this, as from the bottom of my heart, is that I don't know if I've seen anybody who is as committed to dentistry, who's committed to the people and the individuals that he's mentoring, committed to his staff and his entire organization, the way that I see Azim commit to everybody that he's working with. You know, I see his email threads go out from 5 or 6 a.m. in the morning all the way till 12 p.m. at night. I don't know how he does it. But that being said, Dr. Azim graduated from the University of Western Ontario in 2003, and he's been practicing dentistry for over 13 years. He's the owner of Brampton Dental Arts, which is a GP private practice in Brampton, Ontario, focusing on dental implants. He's been a part of numerous training institutes and programs. He's placed over 3,000 implants in his career with a success rate of over 99%. Hats off to you, man. I don't know how you do that. He's also a KOL for DentMat, founder of Tell Show Do Dental Consulting Services. He's the founder out of the Ontario Dental Implant Network, and he's a motivational speaker on treatment planning and case acceptances. If any of you guys are not part of the ODIN or the Ontario Dental Implant Network, I'd highly recommend that you guys join. I'm personally a part of it, and it's been an absolute eye-opener for me. I see the threads, I see all these topics that all the dentists are dealing with, even given the whole COVID-19 situation. And I'm also seeing how Dr. Azim is responding to all of these and how they're maneuvering around everything. So without further ado, my friend, my mentor, Dr. Azim Sheikh.
Thank you so much, Hisham. No pressure, man, no pressure. So I'm gonna go ahead and share my screen. So let's do that. And you can just make sure that we are good. Okay. And can you guys, is that good? Can we see everything?
You're good to go, Azim.
Okay, perfect, excellent. Okay, well, thank you so much, Hisham, for that, and Manisha, for the lovely introduction. It's my honor and pleasure to be here with all of you today, and to hopefully share some pearls, some small pearls that I've taken throughout the years of doing implant surgery. So my email address is right there. It's drsheikh@livedentalsurgery.com. So a little bit about myself. Well, Hisham had already explained. Generally, I've been practicing for about 17 years now. My main focus really is on immediate implant therapy. And those of you who saw my immediate implant seminar or webinar a few weeks ago will understand that basically my practice is all based around immediate anterior molar and full arch cases. I've done a number of implants. I also am now currently the course director and clinical instructor for Hyos and Master Implant Training Program. Most importantly, I am the founder of ODIN. And what do we do at ODIN? Basically, it's a network of doctors. We now have over 60 dentists across GTA. And we chat, we have meetings, we talk about how much nobody's listening to us. I mean, there's very many great aspects to the club. So this is just the website itself. I also actually post my surgical schedule, which is now empty thanks to COVID, but doctors, one of the benefits is they can actually come and observe surgery in my practice. We also have many mentorship opportunities. So this is just a small video about some of the live surgery experiences that you get at the Ontario Dental Implant Network. hope you guys enjoyed that. That took a lot of time to put together. These are just one of the experiences that doctors get. We have cameras that film live surgery, and you can ask questions during the surgeries. So this is an example of our events calendar. This is an example of our, what you can see on the calendar as far as what procedures we're going to be doing on what days. And when obviously we're back in the office, our doctors will benefit from learning and sharing and growing together. And in addition, we have a group chat, which Hisham was mentioning. One thing that I forgot to mention is that just over the next 2 months, this is a membership program that we have yearly, but over the next couple months, I'd really like to extend those who are interested in at least joining our group, no charge or no cost to join our group chat. I think it's really helped doctors kind of navigate through things, and I'm happy to help share that aspect of the club to those who are interested. And when you do send me your email and information, then you can just ask to say, hey, can you please add me to the group chat. So like us on Facebook. I post a lot of cases on Facebook. Also, we have an Instagram page, so do check those out. As Manisha mentioned, Ontario Dental Implant Network does issue AGD credits. We're PACE certified, so we will issue 2 CE points for today. The goal today is to spend the 2 hours. But I do want to make something extremely clear to everybody who's listening. I don't know how many people we have here. Hisham, how many do we have on right now?
We currently have over 232 people logged in.
Okay, so I hope everybody understands that nobody's getting paid to do these things right now. Hisham and both Manisha have taken it upon themselves to organize things like this for people like myself and yourself on their own time. And it takes a lot of work. I can tell you there's a lot of background work that gets involved. There's costs as well associated. So I personally, and I'm sure everybody else can attest to the fact that we thank you both sincerely from the bottom of our hearts to have this type of, I call mind off COVID dentistry connection. I think it's important to have, and they've been doing an amazing job. So thank you both sincerely. And also allowing me the opportunity to be a part of it. So I thank you guys. So now let's get to the goal for today. The goal for today is really to take a step back, okay? And to go through surgery from a step-by-step protocol, from your incision, your flap design, reflection, suturing. Obviously there's gonna be a lot of variation in the, the clinicians that are listening to this. We'll have the novice that are just starting out. We have the experts. The problem that I have, or that I have had, is when I come across doctors and I'm looking to myself first, who think they know everything, And yes, we have, many of us have a large amount of knowledge, but I think the important thing is to understand that you have to be open to learning. And my number one goal, and I got, that immediate implant lecture, I got some great reviews, but also got a lot of pushback. I got a lot of pushback from people in the community saying, you shouldn't be sharing what you're doing. You shouldn't be teaching what you're doing. You shouldn't be showing people what you're doing. And to me, I tell them, sucks to be you, because I will continue to share what I learn, and I will continue to teach every single thing that I know to anybody who's willing to listen, in full disclosure. And I think that's really the true, the legacy that we can leave behind, is that at the end of the day, doctors are going to do things. We're all going to do things. Why can't we teach each other and learn? And that's really what the network is about. Not hiding anything, but being completely transparent. So as many of you know, we have systems in dentistry, right? We have a ReCare system on how to basically answer calls, how to take data. We have a system like a filling, right? So doctor, you drill a tooth. Doctor, you put the etch, you put the bond, you then restore the tooth, right? One day you don't wake up and say, I'm not going to use bond, correct? And you use that system to restore the tooth in every single room, correct? So if you do these things, why can't we have a system for surgery, right? Why can't we have a system? And this is one of the things that I think is lacking in many people's thought processes, is that you hear something from somebody, you hear something from this course, and everything gets so confused. And I'll be honest with you, many of them are trying to confuse you on purpose, right? And I don't know why. I'm not sure why, but it shouldn't be like that. So the goal for today really is to start from a surgery and take you through the steps and build a protocol that you can then apply to every single surgery. Of course, there's going to be some minute details here, but the key here is going to be to have a plan. And I think the plan itself is important, right? You know, everybody talks about treatment planning and making sure that, you know, you have a good plan, but you have to be prepared. You have to take your time. You can't be checking hygiene patients. You can't not have scissors that cut sutures. You'd be amazed. You know, you can't have 5,000 instruments when all you need is 10, right? You have to plan. What is a soft tissue? The first thing you look at should not be the CBCT. It should be, what does a soft tissue look like? Is it thin? Is it thick? How much keratinized tissue do we have? Is there a high smile line, right? What are the patient's expectations? And I should have wrote that down here. It's missing. But the treatment plan needs to include, what are you doing, obviously, right? Are you placing an implant? And if you're grafting, obviously that's going to add some volume. So we need to figure out, how are we going to, in essence, how are you going to put this back? So before you start the case, how are you going to put this back together? Before you've started the case, you need to have the answer to that question. And that closure, when you put it back together, it's got to be tension-free, and you have to get it closed primarily, ideally. And some of you may say, well, Dr. Sheikh, you showed us, you know, 20 cases last week on cases where there was exposure around a healing cap. Yeah, but a healing cap generally will help to seal the site very well, as long as your sutures are done correctly. And I think this is one of the largest things that many of us are missing out on, is how to suture. And we'll talk a bit about that as we go through the steps. So what is your plan? And, you know, when we run the basic implant training program, we ask the doctors, you know, what's your plan on this case? Oftentimes, and this has been with large organizations that are teaching many doctors as well, you know, they spend thousands of dollars going through a training program, and you get to live surgery and you ask them, what's your plan to do this case? And they don't know. What suture material are you going to use? And they don't know. Do you know how frustrating that is as somebody who's a clinical instructor, knowing that these people have spent the time and the money to go through a program like that and have no clue on what to do when it comes time to the surgery? Because at the end of the day, the patient is going to be the one that's affected by this. So these are things that you have to consider, you have to be aware of. Okay, so we're going to go through this case in particular. Okay, this case is a 1-4, patient's missing the 1-4, and somebody's from the US, that whatever that means in US, the number, okay, but 1-4, the upper right first premolar. Okay, there's a bit of a concavity here. So getting proper photographs to be able to assess the site, proper two-dimensional x-rays, so we have a pan and a PA. We're looking at root curvatures, we're assessing how much interproximal space there is, we're looking at the occlusion, and now we look at the CBCT. Okay, and the CBCT shows clearly there's not a lot of bone. So we have a 3.5 millimeter implant there. This is a premolar situation, or remember, an implant is placed based on the biomechanical force it's going to take, not the space that there is or the amount of bone that there is. So ultimately, because this is a premolar, I'd like to place a 4 millimeter implant here, right? So you can see the difference in size. Clearly, there's not enough bone. There's definitely going to be the need for some augmentation on the buccal here. We want to get the implant in the optimal biomechanical position, okay? And now clearly from the axial view, you can see that there's a buccal defect. So remember to evaluate the CBCT. You know, if you see a case like this, where the plan is to remove a central, and you can literally see the root shining through the CBCT, well, that's going to tell you that bone is gone, right? So you should have a plan in order to address the area where you feel like there may be a defect. So having the right instrumentation, I think, is another key important part of surgery, making sure that what you have is what you need, keep it minimal. What is out is what you're going to use. So if you have a surgical setup and you plan to do the surgery, and I come by your setup and I say, what's that instrument for and when are you going to use it? You should know, right? Keep it simple. Know how to use them, get good instruments that are sharp. And again, all you need is really 1 or 2 sets that are good, right? That's all you need. You don't need to spend X amount of dollars to do that. So Hartzell has been kind enough to come up with a kit for me. It was called the Dr. Sheikh implant kit. It's been out there for the last 4 years. Again, it's not specific to Hartzell. You can get these instruments from Cytogenics, also has a kit, but basically it's simple. It's got a mirror, an explorer, some cotton pliers. You'll see I like the Bishop's retractor. It's got a bit of an extra curve to it so it keeps your hand out so you have a better surgical view. You've got your round scalpel handle, your Molt 2.4, which is again, for smaller reflection, which is how we start reflecting a flap, starting to reflect a flap using starting the corners first, which we'll talk about. Again, then using a broader reflection instrument like a Molt 9. A Pritchard is a great instrument for the assistant to help retract. Understanding also that we need to debride the site, so having some curettes, small and large, if there's any infection or issues in the site that we want to remove. Using a back action chisel, I think, is crucial. These back actions are amazing at removing soft tissue tags. And then having a Castro Viejo for suturing really helps to allow us better control when it comes to suturing, and then of course some scissors. Now there's some additional instruments here like a bone well, periotomes, luxating elevators, but I think these are really the critical, and if you count these instruments, we've got maybe about 10 to 12 instruments maximum. This kit is what I use for every single surgery that I do. That's it. That's all you need, okay? If you want to do some tunneling, or maybe you want to create a periosteal pocket or something like that, then you can have some tunneling instruments. These are from Pat Allen's kit. Again, some great options here, but again, don't complicate things. You get what you're going to use. So today is really about the 12 steps, and these are actually the 12 steps to AA. Okay, I didn't mean to talk about those 12. We're going to talk about the other 12 steps. Okay, and those 12 steps, again, it says Dr. Sheikh's name in front of them, but I'm sure somebody else has come up with them. And to make it unique, I put a half in there just to intrigue you, because there is an additional step after the 12th step that I will share with you at the end, which I think is very important. So here are my 12 steps, okay? This protocol, these 12 steps, you can take a snapshot of it. You can take a picture of it. And actually, you know what? I'm actually going to take a picture of this so I can reference this as well, just while we're going. These are the steps that you should go through every single surgery, and these are what we're going to review today. And again, if you're a beginner, you're novice, you're intermediate, or you're advanced, I think many of these points can apply. Hopefully you can all benefit from what we're going to discuss today. So step number 1, local anesthesia. Super important. The largest problem that I've seen when most of us are doing surgery is the local comes out. Okay, the local comes out. And when does it come out? It comes out right when you're in the meat and potatoes of the surgery. So you now have opened a flap, you've drilled the osteotomy, it's bleeding all over the place. And now you're ready to place the implant, you're getting the bone graft material out, and now the patient is feeling something. Okay, everybody's stressed, you're stressed, the patient's stressed, you're in the crucial period of the surgery. So you can't use simple infiltrations when you're doing implant surgery. Okay, you have to remember your local has to be apical to the site that you're working in. Giving a good block or good infiltrations, okay? So regional blocks, PSA, MSA, ASA, greater palatine, these are really, really important things to understand. Malamed has a basic video on YouTube reviewing these techniques. It's free. It's a great reminder on how to do them, but I would strongly encourage you all to look at them. Blocks, long buccal, lingual infiltrations. Again, where does the local come out? On the upper, the palatal, and on the lower, the buccal. So if you know that in advance, time your surgeries. Put a stopper every 45 minutes, you top that patient up. It doesn't have to be a full carp, right? It can be a half a carp, quarter carp, whatever you need to do to make sure that the patient, the freezing, the local is not going to come out. Okay, can you use articaine? Absolutely. Again, typically not for blocks. Okay, we can use them for infiltrations, but I still use articaine in my practice. And again, top them up. Okay, so consider the post-operative as well. Remember, if this patient has a long drive home, you don't want them going home and then the local coming out in their car. This is one of the reasons why we'll also give post-op meds in the office, right? Especially if we're doing full arch cases, the patient can't swallow on their own or is finding it difficult to swallow, then obviously we want to help them give the pain medications in the office, whether it's IV Toradol in combination with acetaminophen or acetaminophen ibuprofen combination, depending on the patient, and at least help them out. Make sure they have their prescriptions in advance. So again, would you want to be a patient going to the pharmacy with gauze in your mouth, waiting 45 minutes to get your prescription filled, right? So again, these are just common sense types of things. I put them under step 1 because again, I feel like they're an important aspect of having a successful surgery is patient management as well. So here's our patient. You'll notice the 1-4 is obviously edentulous. We want to give our local high up. Okay, we maybe want to give an MSA, an ASA, and then again a good palatal infiltration apical to where we're actually going to be performing the surgery. Okay, so the second is flap design. So what are we trying to achieve here? What are we trying to achieve with the soft tissue? And what do we want to try to achieve with the bone? Do we need access? Is there a large defect? Or will there be a defect post-extraction? Okay, are we just going to manage this with a nice envelope flap? Do we need release? Do we not? Do we need to make a vertical so we can have more access? What about a horizontal incision, right? Is there a high smile line? You know, what is the biotype of the patient? So how are we going to treatment plan this? I can let you know right now that most people, think about an extraction, for example. You're extracting an endo-treated tooth. The tooth, you know, the root's fracture. You keep breaking it. Now you drill away a little more bone. You keep breaking it. You drill away a little bit more bone. By the time you're done, your extraction looks like mine, except mine took 3 minutes and yours took 45. We both ended up at the same point. So the key is, don't think that because it's a larger surgical site, the patient's going to have more pain, more swelling. In fact, you will have a better outcome if you can see. The patient wants you to be able to do what you need to do. You're not going back in and doing this again, right? You know, I tell my kids this all the time. If you write a test and you walk away, can you go back in and write the test? No, you can't, right? So again, when you walk away from this surgery, you need to make sure that you feel good in your heart that you did everything that you could to ensure that a successful outcome. And of course, a large part of it is going to be optimizing the patient and setting the patient expectation, but your flap design has a lot to do with this as well. How are you going to close, right? And how are you going to close this tension-free? So there's different forms of flap design. Many of you know that simple envelope, which is great. Now remember, a sulcular incision is a vertical incision. You will get some release with that as long as you reflect past the mucogingival junction. So you really want to do, especially if you're grafting, you want to make sure you really get into that full thickness and elevate. The key here, what I don't like to see is tension on the flap edges, because what happens with tension is you're going to create a vertical, and that vertical is unintentional, and it's very difficult to suture, and that's just one more area that you're going to have issues with potential bone graft failure or bacterial infiltration. So I'd rather have you open it up one tooth more or extend the flap so you can see better for fear of not tearing the flap. Okay? In an edentulous zone where you have multiple teeth missing, like a posterior mandible, you know, having a simple distal buccal release really allows you good access to the site. Again, and it's an easy area to close. Remember, I'm thinking, how am I going to close this? I want to make it easy for myself. One vertical incision, preferably in a non-aesthetic zone. Sometimes we need to do that because we need more access to the site. And again, how are we going to close it, right? Where are we going to put that vertical, right? Again, we need to stay on the line angles and we need to take it up as high as we need, and we'll go through that. But again, it gives you more access. The verticals give you one extra layer of access. What I really am loving right now, it's probably my go-to flap design for many cases, is a vertical incision, okay, on the distal of the adjacent tooth, as you can see here on the 5. And if I want to get a little bit more access mesial, but I don't want to you know, have an issue, aesthetic concern with putting a vertical, I'll actually do a horizontal incision at the base of the papilla. Now, why do I do that? Why don't I take the whole papilla? Number one, there's risk that depending on if there's interproximal bone loss, you may lose some papilla. But number two, how easy, is it easier to tie back, you know, my flap from the flap to the papilla, or taking the papilla and then trying to tie it to the palatal area? It's harder to do that. So this is a really nice design that allows you to close things very easily, very quickly, and it gives you more access. So vertical with horizontal is really, really nice. I love that incision design right there. And then it's a quick tie back to that papilla. Double vertical papilla sparing, again, if you have concerns that are proximally depending on the aesthetic concerns of the patient and the tissue biotype, then this is another design. And then you go again, a large, broad view. This is a large grafting case, immediate implants. Again, we're using a double vertical, again, on the distal of the canines to really stay away from the aesthetic zone. There's also something called a sliding flap. So we can actually make 2 vertical incisions adjacent to the site. And then what happens is that flap will just slide apically coronally. Okay, so these are all different flap designs. This is something called a periosteal pocket. Again, this is Dr. Steegman's flap design for some of his cases where he's keeping the periosteum a little bit more advanced, I would say, but again, another option. And then again, the closure. So aesthetic buccal flap, amazing option for cases. And I've showed you several cases last week where we had to access the apical area. We didn't want to touch the marginal tissue, but we still wanted to have access to this apical area, whether it was the bone that was very thin, given the shape of the bone at the apex. We wanted to just bulk that area up, as Dr. Khan talks about veneer grafting those areas, or access to apical defects like apical lesions, apicoectomies, these types of areas, but we don't want to compromise marginal tissue. Amazing flap design and very, very easy to suture back, in my opinion. Again, highly recommend a resorbable suture. My go-to for those cases is a 5-0 monocryl. Resorbable, but it still takes a good 3-4 weeks. Taking something non-resorbable out of mucosa is extremely difficult. And for those of you who've tried like a Proline or a Cytoplast, getting out of mucosa, it's very challenging. So I like the 5-0 monocryl. And then again, typically it heals very, very nicely, and you get minimal scarring. And even that scarring is fairly high up. So even if the patient in this case had a fairly high smile line, she still doesn't show that scar, okay? And then again, here's the veneer graft because it was getting a bit thin towards the apex and the mid buccal. We were able to graft the buccal of that, her case. So we have, so next step 3, is really the incision. Okay, so once you make an incision and you commit, it's like a marriage. You can't take it back, right? I mean, you really shouldn't take it back, okay? The incision needs to be well thought out, right? It's like, measure twice, cut once. You need to use a clean 15 blade or a 12 blade, okay? Especially, again, for those cases where you're working on distal sites, let's say you have a 3-5, to finish that incision, and you're working in the 3-6, 3-7 site, to finish that incision, get a clean cut, you need to use a 12, a curved blade, to be able to finish that crestal, incision. It needs to be extremely clean, should look beautiful. And I like to actually use the scalpel as I'm cutting and I'm making my incision. I'll use the scalpel to start teasing off the flap initially. Okay, it works really, really nicely. And you want to do 1 tooth past each side. Okay, remember the sulculate, 1 tooth past, extend it. And some would say even 2 teeth, towards the distal and 1 tooth mesial, but really have nice access to the site. And again, it depends on what you're doing, if you're grafting or you're not grafting, right? If there is diseased tissue, which I deal with on a daily basis, we will be splitting that tissue. So if there's a large buccal abscess or buccal tissue that just is necrotic, then what I will do is I will grab that flap, that healthy flap at the margin, and I will use a new 15 blade, and I will start sectioning it to leave the healthy tissue on the flap and all the diseased stuff on the bone. Because what's easier, cleaning diseased tissue off a mobile flap, right? Or cleaning it off the bone? It's much easier to do that on the bone, off the bone. So that's why the incision is critical. And again, you got to be careful. If there's diseased tissue, you got to go slow because you don't want to perforate through the flap. Okay, but again, so here's our incision. And again, you're going to notice this is the 3-6, 3-7 site. It's very difficult to take a 15 blade and continue your incision to hit the distal of that 3-5. So that's really where that curved 12C blade comes in and helps you finish that. That incision should be nice and clean. So same thing with the case or the case example that we're using with the tooth 1-4, the upper right first premolar. Here, all the incisions have been completed. Okay, there's no reflection at this point. It's just incisions. They're clean. You can see the bleeding points or some bleeding points. You'll notice I did a 1 vertical. It's a little bit hard to see here. on the distal of the 5, and then we did 1 at the base of the papilla between the 1-2 and the 1-3, just to, again, allow us more access because we have to do some grafting on the buccal of the 1-4. Okay, so now, so all our incisions are completed now. Okay, so we're taking one nice clean incision down to bone. Okay, we're not filleting, we're not making multiple cuts. All right, we're committing, right? It's like a marriage, you're committing to this. Okay, now we're on to reflecting our flaps. So when we get to reflecting our flaps, and this is something I paid, what, I'm gonna say $5,000 to take a course to learn that when you reflect a flap, start with the corners first. Okay, it's super important because if you don't, where do you get tears? You get tears at the corner of the flaps, okay, or where there's tension. So you always want to start on the corner. And what do you use to start on the corners? A molt 2 or a spade or something that's small that can just reflect the corners. Okay, the good thing with a small instrument is you can reflect minute areas very effectively. Okay, the small thing with a small instrument is if you start using a small instrument to reflect broadly, you run the risk of tearing something or perforating through the flap. So these small instruments are used simply for reflecting the corners. Okay, so you start with the molt 2, then the molt 4, which is a little bit wider. And once you've reflected full periosteum around the corners, okay, and then even the crest of the flap, then you can start doing broader reflection with a molt 9. Okay, so it's important to remember how these instruments get used. Okay, how do periosteal elevators get used? Okay, the way that they get used is you push on bone. All right, you don't pull the tissue off the bone, you push on the bone, and as a result, the flap will lift off. The flap lifting off of the bone is secondary to what you're actually doing with this instrument. Okay, so I see again some doctors, and myself included, sometimes I forget, I start trying to pull the tissue off the bone. You don't want to do that. You want to push as hard as you can on the bone, and as a result, the tissue will reflect off, and you will get better full periosteum that way. Okay, when you reflect, you need to remember where do you need to reflect to. So if I'm grafting a site, okay, I want to keep in mind where is my bone graft going to go and where's my membrane going to end. Okay, so the key here with reflection is to undermine the flap. Okay, if you have verticals as well, undermine those verticals, because if you have a membrane and you want to tuck it in there, okay, so think about the steps now. Everything's very calculated. You now have a membrane, and the membrane, you're trying to push it into this area where there's a vertical to try to let it sit, but you haven't lifted it up. Well, now there's a membrane there, and now you have to go back and do this reflection all over again. Okay, and sometimes reflection causes bleeding. So that just complicates things. So when you reflect, make sure you reflect everything that you need to, so that you can anticipate when you go to place your membrane that it will go into that site automatically. So I'm reflecting in anticipation of what I have to do later on. Okay? And when I talk about P and L, that believe I meant there palatal, okay, or lingual. You need to make sure that you reflect adequately. So a lot of doctors say, you know, my assistant sucks. She doesn't know how to retract, right? Well, it's because it's not the assistant that sucks, it's you that suck. Because you haven't reflected adequately in order to allow your assistant to retract properly. So this is super important. Palatal oftentimes doesn't get reflected properly, nor does lingual. Okay, so you want to make sure you do that. And then I have this 3 millimeter rule. And the rule of thumb is generally where I need to graft to, okay, wherever my graft is going to end, I want to reflect 3 millimeters past that graft, okay? Because what happens? And you all know this. You know, you start packing the bone, it looks beautiful. Hopefully many of you are using sticky bone, because I can tell you it will change your life and your ability to graft, okay? But sticky bone PRF is a must. It's not an option, it is a must, okay? I'm not talented enough to manage bone without it. So my advice would be strongly look into PRF. But imagine you have bone, and now you have your membrane. What does everybody struggle with? That stupid membrane. And the reason why you struggle with it is because of this step right here. You haven't reflected properly. You haven't reflected enough. And now at that stage, you're going to go back and you're going to try to reflect. And now your bone's over here, it's over there, it's on the patient's chin, and there's no bone at all where it needs to be. So I can't stress this step enough, which is reflecting your flap properly. I'd rather see people spend more time on these first 3 to 4 steps than the entire procedure itself. Because if you can do these well, then the rest of the surgery goes very smoothly. Okay, so here's an adequately reflected flap. You can still see there's a bit of tension underneath that canine area, so I'd probably reflect that a little bit. And you see this vertical here on the distal of the 5. I really will take a Molt 4 and I will undermine that whole vertical, just in case my flap decides to go under there. And I'll probably throw some PRF membranes that will cover that whole area, that'll tuck underneath that area as well. Why? Because I want PRF underneath my vertical incision, okay, or any vertical incision, or even horizontal incision for that matter. It just helps to speed the soft tissue healing, okay? So here's a crestal portion. Again, you'll notice we have some tissue tags here. But what's important to note is the palatal is very well reflected. How deep is it reflected? I will take a Molt 4 and I will shove it in 1 centimeter down the palatal flap, 1 centimeter. And I do that for medial to anteriors as well, because I can literally take now my drill, put it along the palatal bone, and I can have an estimation as to what angle the palatal bone is. So I feel that angle, I come out and I go right in. And that's my first hole. Okay, that gives you a really good estimation as the angulation of the palatal. Patient's not going to hurt anymore. Okay, you just suture that back, patient will heal. Okay, it doesn't hurt the patient anymore. So here now I'm just showing you another example of adequate reflection. Okay, you can see that buccal concavity very nicely where I want to graft to, and I'm ending 3 millimeters apical to that. Okay, and again, you can see the occlusal portion very nicely as well. And it's slightly, what I want to do is slightly go a little bit palatal so I can pull a little bit more of that keratinized tissue towards the buccal. Okay, so for a case like this patient actually had the 2.5 and the 2.6, multiple apicoectomies, huge lesions, came in with buccal swelling. So again, what I did here was I split the flap. Okay, so you'll see that there's all this diseased tissue on the bone, and there's healthy tissue on the flap, basically. Okay, and then at that point, again, adequate retraction. If I know I'm gonna have a perforation because I'm placing the implant in the ideal biomechanical position, okay, otherwise the implant would be almost like 60, 70 degrees out towards the buccal, then I need to have adequate reflection to ensure that I have access to this when it comes time to graft, okay? And then there's our bone graft. This is all autogenous bone taken from the ramus. So another important thing is for those of you who are doing full arch, okay? Sorry, I gotta stretch my neck here. So full arch is, it's very difficult to lift those cases, to reflect in those cases. So my strong advice would be, and those of you who've done enough of these will know that your tissue is gonna tear, okay? It's gonna tear somewhere, especially in that lower mandible arch, okay? Or even in the upper anterior where you start getting into frenectomy, the frenum, right? My strong advice would create some controlled tears. Okay, what do I mean by controlled tears? Is use a 15 blade and make an incision on the distal buccal on each side. Okay, it is gonna enormously help you with reflection of these flaps. I'll even make one, so I'll make one on both sides, and I'll even do one in the anterior, right in the mid-anterior. When you do that, the reflection is enormously, well, it's much more facilitated, let's put it that way, it's much easier. Once we get to placing our implants and grafting, then it's a very easy tie back. It's nice, it's clean, it's neat. This is a running continuous suture, and it allows you to just open, reflect, have access, and close things back so it just looks like a work of art. Okay, and if it looks like a work of art when it's done, it will heal like a work of art. Okay, that's very, very important. I can't stress that enough, and this is so. Same thing on the lower. You'll notice I made an incision mid-anterior. And I did that purposely to allow reflection. In these cases, especially the ones that are severely resorbed, maybe have 7, 8, 10 millimeters of bone, they're really hard. You're pretty much right into muscle right from the get-go. And the flap is very thin. It tears right away. So by doing these, again, allows you to expose mental nerve as well very easily, very effectively. And we do that for all those cases. We'll then go ahead and prepare my two distal implants, and then we'll space our remaining implants. It's a very easy, quick tie back and suture. Okay, what I don't like here, and normally what I do at the end, you'll notice this running continuing suture, is you see that line is sitting right on the incision. What I'll do is I'll pull those away so that they're not sitting on the top of the incision. And I do have PRF here as well. I normally layer a couple layers of PRF membrane on top of that, and it heals very well. Okay, so I think it's very important to understand that reflection is one of the largest problems that we have. It's kind of like, if you know you're going to have a problem, okay, then you can be prepared to deal with it. All right, but most of us know we're going to have a problem, but think maybe it's just going to go away. And then when it comes time to doing surgery, now it's surgery, and now you're dealing with that problem, right? And now you're backtracking. So why? Why do we put ourselves through that? Okay. So step 5 is retraction. Okay, retraction is extremely important so that you can see what you're doing. And remember, patient positioning also helps. Remember, the patient can move their head this way, this way, this way. The patient wants you to see, and you need to see. Okay, I do surgery standing up. I feel like I have better visual control, but adequate reflection is required in order to retract properly. And I normally, whoever's on the buckle, so let's say, we're working, I'm right-handed, we're working on the patients, in this case, the 1-4, I'll be holding my biceps, and I like the biceps, like it's got that extra curve to it, so it keeps my hand away, I can see more. And and if you like the Minnesota, that's fine too. It's a bit firm. So for larger cases, again, the Minnesota is a bit more firm. The biceps has a little bit more give to it, so your hand gets a bit more tired. But for the palatal or the lingual aspect, the Pritchard works really, really nice. Okay, the Pritchard is broad enough where it can reflect the flap, okay, retract the flap nicely. It's even broad enough on the lower, it can even keep the tongue out of the way as well. So you can retract the flap and the tongue out of the way. And what's important is how we retract and when we're moving from inside and outside the patient's mouth to have a handoff. So this is what happens in most cases. Doctor's doing a surgery, now what happens is we need to leave to get put a different drill or do something, and you let that flap go, okay? Now you go out, you grab your instrument, your tool, whatever you're using, your drill, and now you have to go and you have to find things again. And you're spending like 10 hours trying to locate, get the flap, and now you're tearing it, you're compromising the blood supply, and you're treating it like mush, okay? And by the time you're done, you've added about 12 minutes onto your surgery that didn't need to be there in the first place. So handing off is crucial. Keep resting on bone. Remember, these instruments are meant to rest on bone. They're not pulling tissue. They're resting on bone. And when I'm about to leave, my assistant will grab the retractor. I will leave. I'll go do my stuff. I'll come back. I'll grab it, and she knows that she can let go. Okay, so we want to keep things resting on bone and not pulling on the tissue, okay, by retracting properly. So this is a case where I'm pulling on the tissue. Bad Azim, okay, bad me. I shouldn't be doing that, all right? But for larger cases, if you have adequate reflection, you can retract these cases. This is a large anterior graft, and the mandible has got periosteal stabilizing, membrane stabilizing sutures. This is, again, a large upper case. Again, I'm resting this instrument. You can see the biceps, right? See how it has that extra curve? You can't even see my hand in this picture. So it gives you better access. I mean, some doctors even use Optrogate. That works fairly well as well, okay? But having good access and resting your instrument on bone, I can't stress that enough. So again, you'll see, here's an example, again, of me resting on bone on the buckle, And my assistant, she's using a Pritchard. You can see that's been slightly battle tested, okay? But again, she's resting that, and it's resting on bone and pulling the tongue out of the way. We have a nice, clear surgical field of view, and that's crucial when you're doing surgery, for any type of surgery, okay? So I'm hoping that this is benefiting some out there. Again, I'm speaking to a laptop at this point right now, so bear with me, okay? So step 6, so we're about halfway here. Debridement and site preparation. Extremely crucial as well, okay? You need to clean the bone. So I don't want to start prepping an osteotomy. Now I have my implant. Now I'm starting to place my implant. I see this little soft tissue tag that's sitting right next to my osteotomy. And as you start placing your implant, you see it start spinning, and now that soft tissue starts getting in between the threads and it starts going down in your implant. Now what happens is, like, what do? I don't know. I don't have a backup implant because I didn't order enough stock. You know, I'm already running behind because I have another patient I need to see. My hygienists are waiting for me to do a check. And you know, this patient, you know, already gave them a deal. So, you know, whatever. Okay. So you need to do things. Again, that's the reason why these steps are made, is clean the bone. You don't want to have any regrets, right? So clean the bone. Use a good back action chisel. That's sharp. That works. And I get my hygienist to sharpen these. Okay. I love burrs. Diamond burrs, okay, are amazing. Coarse diamond burrs, not carbides, but diamonds. Okay. Brasseler sells these long surgical diamond burrs that I'll use oftentimes to trough areas that I need to accommodate healing abutments, but also to remove large sites. And I really want to see nice and white. I want to make sure that there's no tissue in that area. Curettes work well, they're okay, but I like burrs better. And then copious saline irrigation. Scaling and root planing of adjacent teeth, root surfaces are important to do, okay? We want to make sure there's no calculus in the area. If there's a rough restoration, you can polish it. My advice would be, if you have to polish restorations or you need to create guiding planes, that you do those before you open the flap, okay? So that's just an aside, that you should do that, because again, you don't want amalgam or you don't want debris getting into an open flap and then rinsing it out and then wondering, oh, did it fail because maybe it had some bits of something in there, right? Okay. Alveoplasty, again, if you're doing a locator case, an all-on X case, and you need to create prosthetic space, again, for typically an average all-on case, we're looking at about 15 millimeters from implant head to the top of the occlusal of the teeth. And then this would be the time that you would do it. So for those of you who are doing all on X, you know, don't waste too much time taking out the teeth, because by the time you do the reduction, you're probably just going to be able to flick out the roots at that point. But it is important to do this. If there are teeth that need to be treated in that area, then you can go ahead and, you know, you can apply some of the EDTA or the Pref gel just to, again, get those root surfaces ready for grafting. Okay, and you saw one case last week that I did on a hygienist. Her name was Maggie, who had resorption on a lateral, on a central. We had to take out the central, but the lateral had a huge monster defect, and we need to graft that as well. So I followed this exact same protocol, and at this step is when I would apply that Pref gel or EDTA, okay? Not the Emdogain, but just the EDTA, just to clean the surfaces, okay? And remember, this is site preparation. So if you need to decorticate, okay, and I typically will decorticate in mandible, I don't necessarily do it on the upper, then do that before you place your implants at this step. Why? Because you go ahead, you place your implants, and now it's time for bone grafting. And now you start using, let's say you're lucky and you have the Meisinger burr, which is from the Urban kit, which actually is a decortication burr. It's very nice. It just literally has a stopper on it. You just drill and it goes right through the cortex. Even with a stopper, you can still hit your implant, right? So it's important to do the site preparation and debridement at this stage so you don't have to move and maneuver around the already placed implants, okay? So there's a thought process to these steps. I hope you guys can appreciate that. So here's the osteotomies, okay? And the decortication was done prior to the implant placement. You can see there's one that's sitting right on top of the implant, basically. So had I done that, you know, then I probably would have hit the implant, okay? And again, look at the debridement. Do you see how clean that looks? That was that same case with that buccal, you know, those apicoectomies that were performed on the 2526, the upper premolar and molar. Look how clean that looks. You can eat off of that. Well, not really, but you know what I mean. Okay, so it's just clean, you know, it's got to look nice and clean. So there's no debris and there's no tissue tags. I'm not worried. When I go to grafture, there's nothing else there but clean bone. Okay. Step 7, now we're getting ready to place our implant. You need to have good visual control. Okay, remember the patient can move around. If you're standing, you can move around. Do whatever you need to do to make sure you can see. Direct vision is best. Okay, so I don't care where you are, you should be able to get direct vision in most cases. Okay, I'll typically get my angulations right mesial distal, and then I'll move around the patient so I can see the buccal lingual. And then I go ahead and make my osteotomy. But use indirect vision as well. Number 1, use your assistant. Okay, they're invaluable, all right, on angulation and you know, depth and these types of things. Secondly, use an intraoral camera. Okay, so you don't have to buy a $3,000 Carestream camera if you don't want to, although that's the one I use and I love it. Very high definition. These are some of the pictures you're seeing in the presentation. But you can use a mouthwatch, right? Or another version of that, which are very inexpensive, maybe $200-300, and at least help you during the surgery, and also will help with documentation. Because again, the only way that you can truly learn and grow is by evaluating your cases, not somebody else's cases, your cases, and seeing what's happening with them. Okay. Taking a guide pin x-ray, cannot stress this enough. You know, I got into a phase where like, you know, Azim, you're so good, you don't need a guide pin x-ray. And I can tell you, as I started getting back into teaching with the basic implant training program, I started realizing, man, I'm missing out on not taking this guide pin x-ray because my angulations were not as good as they could have been had I taken that. So guide pin x-ray, very important. If you're doing guided surgery, like with the high Austin system, they have the one guide, you can still take a guide pin or a guide drill x-ray. You can take the guide out, you know, you can put the drill in and you can tie some floss on it, and then you can take an x-ray with that as well. But whatever you need to do to ensure your implant is in the optimal position, guided obviously helps dramatically. But if you're doing freehand, again, a guide pin x-ray. And really our goal is for an optimal 3D position, right? For biomechanical function and optimal aesthetics. Primary stability, when we're placing our implant, I talked a lot about this the last course or the last webinar, is using cortical bone. Okay, so you have crestal cortical bone, but you also have cortical bone apically, and that's either the floor of the nose, the floor of the sinus, engaging that. Again, there's cool things. I'm doing a lecture actually this Thursday on the CAS kit, which is a crestal approach sinus kit. It's invaluable. It allows you to penetrate through the sinus floor, not damage the membrane, and then have your implant engage in that cortical floor, right? You can also do sinus lifting, obviously, with it. When you place your implant, and in my case, I'm using a crestal implant, typically a subcrestal implant, normally 1 to 2 millimeters, especially if you're developing proper emergence, for example, a molar site, you want to place your implant even deeper. Well, how are you going to seat your healing above it? Okay, so I like to trough the bone. Most companies have a bone profiler. It's something that you can use to place on top of the implant and cover or protect the head of the implant, and then the drill will remove it. Typically, those bone profilers will remove about 2 millimeters, but if you need more, then what I like to do is put a cover screw on the implant, and then I take a long surgical round diamond, coarse diamond, like a size 6, and I literally trough the bone. So here's an example of a case I showed you guys yesterday. This was a through and through communication, right from the buccal soft tissue, right through to the palatal soft tissue. Okay, and we did an immediate anterior here, so some of you may remember that case, and I showed you the post-op CT as well. But this was a liniment. I tried using it in my initial drill, and when you have holes like this going everywhere, the holes pull you in different directions. So the liniment, which is a side cut drill, it comes standard in the high Austin kit, allows me to position and move the osteotomy where I want to. Okay, I'm getting palatal positioning here, and I actually can use this drill as a guide pin x-ray. Okay, so I put my next drill in here, and I can actually use the drill. So don't think a guide pin has to be a guide pin. Okay, it can be the actual drill itself. And again, we would tie floss to this and then take our PA. Okay, now again, when we're placing our implant, I'm constantly looking at the direction of the implant. And for anteriors, I like to use their hand driver. They have a hand driver, most systems do. So you can keep apical pressure as you're screwing the implant in. You can appreciate that if you put a torque wrench and you start pulling this way, where's your implant gonna go? The path of least resistance, which is the buccal, right? It's gonna change angulation. So taking these guide pin x-rays while you're placing your implant, looking at your depths, and again, knowing your depths are really, really important. Okay, taking pictures from different angles, intraoral cameras, really helps to get one to appreciate the direction that they're going at all times. Okay, and in this case, okay, so this is actually the case, the 1-4 site. So here you'll see this is a densiber, which actually works in reverse, counterclockwise at 1200 RPM, and it densifies. You can also sinus lift with this. They're just expensive burrs. So I still like to use my cast kit for these cases, but I thought I'd use Densa here. And this case is going to need some crestal sinus lifting. So this is the one reason why we did that. So you'll see we did our Densa, and you can actually see here, and I'll show you a little bit later, but we added some bone apically. You can see it right at the apex of that osteotomy there, okay? So the implant is now being placed, correct? Okay, so we place the implant, but now we place it at the proper depth. The depth typically is about 3 to 4 millimeters beyond the CEJ of the adjacent teeth, or a millimeter or 2 below the crest of the bone. And now there's bone in the way. We won't be able to see it, our healing abutment. So here is the troughing that happens. You'll see I have nicked the crestal portion of the implant, but it's fine, nothing happens, okay? And people say, oh, you shouldn't do that. You shouldn't do that, okay? But if it happens, it's not the end of the world, okay? You just need to make sure you debride the site and then make sure there's no little bits of debris in there. But if you want to be safe, use a bone profiler, okay? So now we have room, and I'm just shaping the tissue like I'm shaping it for the crown, okay? And at this point now, my implant is placed and my site is prepared for a healing abutment. What happens is, oftentimes we place the implant, we put the healing abutment, we take a PA to find out if the healing abutment is seated. And that is wrong. You should know if the healing abutment is seated. You should be able to feel. If you have to start tightening things, then there's a problem. Okay, so for this case, for a premolar, I like a 5 millimeter wide healing abutment. The Hyoscine system has up to a 7 millimeter wide healing abutment, which really, again, allows you to develop the emergent profile right at the time of surgery as opposed to doing it later on. Okay. So step 7 was implant placement, right? You're following me here? Let me check my list here. Hang on. Here we go. Yeah, we're good. 7, implant placement. 8, periosteal release. Now, Tina actually showed us a great video on periosteal release. I just found out how to do a periosteal release properly about a year and a half ago. And I've been doing this for 13 years. Okay. So what a periosteal release is, and understanding what it is. In essence, what you're doing is you have a flap. You're pulling it out, and it's attached down there at the base somewhere, right? What you're doing is you're taking a new 15 blade, and you're, in essence, cutting that in half, basically. Okay, you're cutting it in half. So you're leaving some of the tissue on the bone, or the periosteum on the bone, and you're cutting the rest, and you're releasing this. The flap starts releasing, okay? You need to use, so what I like to do is I like to take cotton pliers, okay, because they're not too aggressive. I like a new 15 blade, okay? And you want to be able to look on the outside, see where you're at, and then just make that one clean incision. They're not stabbing, you're not going multiple times through it. Because what happens with a periosteal release is you start getting bleeding, right? Okay? So I'll talk about that in a second. But it's clean, it's continuous, and you need to connect it to the vertical if you have one. Okay, that's super important. You get an additional, I think Dr. Stigman was showing like 120% more release if you connect it to a vertical, if you needed a vertical, okay? And oftentimes if your assistant's holding that flap, he or she will be able to tell you like, oh wow, yeah, I'm really feeling this pull. And you'll be able to feel it as you're doing it. But it should be a nice, clean, intentional cut. And what you're trying to do is you're just trying to create a slit at the base of your flap, leaving some tissue on the bone, which is the periosteum. I hope that makes sense. I'll show you some pictures. But if you do this, and remember, this is done at this step. It is not done when you already have bone grafting and membrane in the site. Now, why? Who can answer? I'm just kidding. I know you guys can't. So the reason why is because it bleeds like a mofo, right? It bleeds. You get bleeding. And so when you do this, you check your release, okay? And then you compress the site for 1 to 2 minutes, okay? Once you compress this is what normally happens, okay? You do it now at this step, you don't cut, you don't compress the site. Now you get clot formation at the base of your flap. By the time you get to actually placing your bone and putting your membrane, your flap no longer will release, okay? So if you're having that problem, that's why. Others will place their bone, put their membrane, do their cut. Now remember, your 15 blade here now is touching your membrane, your bone's going here, it's going there, it's going everywhere. Now there's bleeding all over the place. Now what do? It's a hot mess, and it doesn't have to be, okay? Do your periosteal release now, okay? And compress the site. Once you compress the site, for about a minute, even just a minute, you'll notice there's no fibrin clot formation in that at the base of the flap. You still have your release, and there's zero bleeding, okay? So here is what it should look like when you release. You'll notice that I've literally just cut the flap in half at the base, okay? And there's not a super high chance of perforation here because you're fairly high up generally, okay? Your flap is broader and there's mucosa, so when you pull on the tissue, it's pretty hard to perforate at that area. But generally you're trying to leave maybe about 1 millimeter thick of tissue because again, if we're doing membrane stabilizing sutures, and we would use that tissue to suture to. Okay, so that's in essence what you want to do. You want to make sure that it's broad. Sorry, I hope I'm not covering things, but you want to make sure you start from the mesial and go towards, start from the distal and go towards the mesial. So one thing I forgot to mention, when we reflect a flap, we push, right? It's easier for us to push when we reflect. When we make an incision, we pull towards us. It's easier to pull. It's harder to push and be more exact. So that's another important point I forgot to mention. So when we cut, we always want to start from the distal, so from this area at the base, so let's say from the 1-5 area, and make a nice clean cut from the vertical, so include the vertical at the base, and come right to the mesial and leave that tissue. And you'll see this whole thing, you should be able to pull it right over the patient's face, basically. It'll release quite a lot, all right? And again, each vertical that you add, you get more release. If you do double vertical, you get extra release. There's numbers on that, which I don't want to share. Okay, if we're working close to the mental foramen or on top of the mental foramen, there are ways to release the foramen on top of that, whether you're using Dr. Urban's approach, which is with a 15 blade, or whether you're using Dr. Steegman's approach, which are with instruments, which I like better, called TK Steeg instruments. But here, I don't know if you can see this. This is actually the mental foramen, the nerve bundle, and then we just release on top of that bundle. The bundle is very robust. I'm not saying anybody should do this, okay, because I know I'm already gonna get heat for what I'm saying. So nobody should do this unless they feel comfortable and they've had adequate training and experience, okay? But it is possible to do that, to release the periosteum above the neurovascular bundle, all right? So when we're grafting a site, for example, like here, where we have to place 2 implants in the 3-5 and the 3-6 region, and the foramen's sitting right there, how are you gonna graft? How do you cover the bone, right? And you need to be able to release on top of that. So with that said, periosteal release, put some compression, okay? While your assistant is compressing, you now have 1 to 2 minutes to get the bone ready. And I think when you plan, and I think at the beginning of the stage, I talked about planning your surgery. You know, I'll give you an example. When a patient comes into my office, okay, I do a little chit chat with them, you know, review their medical, make sure everything's good, review the treatment plan with them. And I tell them, okay, you know, we're gonna give you some freezing and then we're gonna draw some blood. So literally, boom, the patient's sitting back, I give them local. As they're sitting up to have a rinse, I'm taking their arm and I'm drawing my own blood, okay? Once I draw blood, that gets spun to make PRF. I then sit them back. I top up a bit of local. I'm now gowning up, and I have, because my spin speed is about 2,700 RPM for 12 minutes, that gives me about 10 minutes to basically open the flap, take a tooth out, debride the site, so I'm ready to now mix my bone. Okay, and then for those offices like myself, I have a second assistant now. She does all my bone. So we have one sterile one who's doing the surgery with me, who's completely sterile, and then one non-sterile. They call them, I think, in the hospital, dirty nurses. Okay, I wouldn't say that to your assistant, but basically, she's there to do all the things that we need. Okay, so when we're now, so again, have a thought process to your surgery so you can be as efficient as possible. Remember, the patient doesn't want to be there for any longer than they need to, nor do you. So don't waste time. Don't sit there and talk about other stuff. We just want to get to what we need to do. And again, keeping the surgical site more open for longer can also impact the healing of the case too, right? So keep that in mind. So now we're at bone grafting. Okay, with bone grafting, we have separate instruments for grafting. That's super important. So you can't have the same instrument that you're using in the patient's mouth to now mix your bone grafting material. Take it out when you need it. So you don't want to sit back and say, oh, did my graft fail because maybe I kept it out too long or it was contaminated? Okay. My recipe, as I told you, is a sandwich technique. I always put autogenous bone on the threads. If I want autogenous bone, you can get it. You can get it from the site you're drilling by drilling slow speed, 400 RPM with no water, and then irrigating the site thereafter using a back action or a safe scraper, a micro-os. Then I like my allograft xenograft mix, which is a 50-50 ratio. I shared that with you guys last time. And then I make it into sticky bone, which using IPRF or Dr. Shukran's protocol. And what I like to do is, and this is important, compact it. Where do you need the bone? That's where it needs to go. So if you need it at the crest, in most cases, then that's where you need to compact it. Okay, I like to compact it. That's where it's going to go. And then when I put my membrane, which is our next step, the membrane will push it down a little bit, but we still want to keep it up at the crest. And this is where sticky bone helps out dramatically. Okay, I like to account for about 20 to 30% resorption. So I'll typically add more volume. And you really want to make sure there's no dead space. Okay, so you want to make sure it's well compacted and then and that there's no dead space in that area. Okay, so here's this a case on the lower right, for example. Again, I'm putting autogenous, so there's two implants here, 4, 6, 4, 7. We decorticated. You can see clearly there's some thread exposures. So for this case, I put, for every case, I do the same way, autogenous bone and then sticky bone. And this case, that case actually, I think I'll have it coming up. I used the sausage technique with Dr. Urban. But again, that's just one option. For the anterior, again, a lot of thread exposure. There's the micro-os, again, just scraping locally. Again, you're just scraping from the local site some bone. You can collect quite a bit. And then we're placing that on top. And then we're putting our sticky bone on top of that. It's just like putty, goes right over top and it stays, okay? Now for our friend, the membrane. Who hates a membrane? Let's see your hands. Yeah, I can see. I'm just kidding. I can't see anybody's hands. Everybody hates the membrane. And the reason why is because you make yourself hate it. Okay, the way you do surgery right now, you do it to yourself. Okay? You're not reflecting. You're not thinking about how much volume. There's all these things that we talked about in these steps that if we do, the membrane will be an easy part to do. Okay? So what are you going to use and how are you going to stabilize it? Okay, adequate reflection makes it easy. The number one way, this is why I love immediate implants, is because if I get my implant stable, which I can 99% of the time, then I like the healing abutment technique. I use my healing abutment, I cut a little hole in the membrane. That's the easiest way. Other than that, it's a little bit more challenging, right? So I'm gonna go through some options for stabilizing membrane, okay? And again, you shouldn't end your membrane on the vertical, okay? But I will try to tuck it under the vertical and then cover it with PRF. I feel like that's okay. But you want to cover the graft and things have to be stable. Remember, for bone to work, it can't move. It's got to be stable, right? Has to be stable. And you want to make sure that there's no dead space as well. So having a tissue punch, these little tissue punches come in sizes. My go-to is a 4mm tissue punch. And guys, I hope you appreciate this slide because it took me a damn long time to do these animations. Okay, so we've got a square membrane. Let's call it a 15 by 20. I like to round the corners, actually top and bottom. Okay, and then what I do is I fold the top third in half and I just cut a little diamond in it. Okay, if you want, you can use the tissue punches, but again, I'm Pakistani, I'm cheap. I don't like to spend money if I don't have to. So the scissors are free. Cut a little triangle in it, open it up, and now you got like a little diamond thing there, right? And you can put your healing abutment in it. Okay, you can do the same thing with PRF membrane. So this is a tissue punch, but some people again will just use a 15 blade. And again, I find that the 4 millimeter size is really nice because it kind of stretches over top. Okay, and this is the Karate Kid technique. You know, those of you who've seen, I think it's the second Karate Kid where Daniel-san has to chop through like 7 layers of ice. You know, you can line up like 7 membranes. My record right now is 6. The 7th one always slips off, so I'm working on it, guys. But the Karate Kid technique works really nice. You can punch through multiple membranes at the same time. So here's my healing. Here's my membrane. Okay, and this option, you can see I've cut the diamond. If you make it a bit too wide, try not to get too close to the edges, so you can still have, but even if you do, it's okay. And there's my healing abutment. And it just literally holds the membrane like no other. Don't cut the hole too small, okay? Why? Because we want bone at the crest. So I literally will push the bone as high as I can right up to the healing abutment. And then as I fold my membrane down, it's gonna push it right to the crest of the implant. You guys get what I mean? I hope that makes sense. Okay. The second option is site secured. So think about it. If you've lifted an envelope flap, okay, and you've lifted it to a certain extent, and you put your membrane in there and it matches somewhat of the similar size, where's it gonna go? It's not going anywhere. So that I call a site secured membrane because it's got nowhere else to go. Okay, you can use tacks or pins. So again, there's Singer, which makes a great kit. They're called, God, I forget what they're called. Anyways, they're tacks, okay? Pins, MC Bio makes some nice pins. If you have 2 implants, again, you can double healing abutment, maybe use a wider membrane, like a 20 by 30. Singer master pins, there you go, they're called master pins. Okay, so this is a sausage technique, again, where we pin at the bottom. I like to pin at the bottom first, add my bone, and then I just put one at the top, and it's literally like a sausage roll of bone, and it doesn't move at all, okay? In this case, again, I just use my healing abutment. So let's go back to our initial case, right, the 1-4. So we're just using our healing abutment, adding some autogenous bone, putting our sticky bone, and then boom, just folds right over it. It sits beautifully, and it's stabilized. It's okay if collagen is sitting on the tooth, you can tuck that in, okay, and then put PRF membranes on top of that. We're almost there, guys. Suturing, what material do you use? Okay, what thread size, what needle size, what technique? How do we close the vertical? How do we reproximate the tissue? Suturing is the hardest part. So my advice would be for most of my cases, I'm using Cytoplast. I'm using 4.0 Cytoplast on a 16 millimeter needle. Cytoplast is a monofilament. You get no plaque on it. You just have to know how to tie it. Okay, and sometimes it's a bit of a challenge in knowing how to tie the knots on these. Okay, monocryl, 5.0 monocryl is my newfound love. It's a beautiful suture. It is just like Cytoplast, except it's resorbable. Again, these are monofilaments. Okay, so our goal is in essence getting tension-free primary closure. So to keep things simple, if I'm doing a grafting case, I'm using Cytoplast and monocryl. Okay, if there's no grafting involved, then you can use whatever you want. Okay, you can use a chromic gut, you can use Vicryl or whatever. Okay, the thread size again depends on what site you're using, right? So for most cases, most people are using a 4.0, and remember, the smaller the number, the thicker the thread size. So the 4.0, if we're doing something finer, so for example, let's say we're closing a vertical, right? That tissue sometimes is very thin, especially in the interior. We don't want to take, a bigger size thread. And again, most of the bigger size threads, like a 4.0, come with bigger needles, like 16 millimeters. We want, for finer areas, we want to use something smaller. So a thinner thread, like a 5.0, okay, and a smaller needle, like a 13 millimeter, would be what I'd recommend using, okay? Because again, you can just tear stuff if you use something too big for the area, all right? The technique, believe it or not, people think, oh, Dr. Sheikh must use these crazy suturing techniques. Not really. I use a double simple interrupted suture. And that's it. That's typically, and I'll talk about how to close a vertical, but that's my go-to suture. Okay, so this is a membrane stabilizing suture. I infrequently use this, meaning I don't use this very often. I don't feel like there's a whole need, and it's a very complex suture to do because you have to have access to the apical periosteum once you do your periosteal release, okay? But in this case, I was demoing a periosteal suture, but I don't feel like we needed to have one here. We had the membrane was stabilized with the healing abutment, okay? But you'll see here, here's cytoplast, and I think what's important to make sure everybody knows if you're using cytoplast is to make sure you keep the tails long, because in case your knot is not tight, it can slip up. So if your tails are too short, then your suture is gonna open, okay? But the double simple interrupted suture is my go-to. So what I do is I start on the buccal, and I go 5 millimeters from the margin of the tissue, and then I go deep on the palatal again, 5 millimeters. And then I come back around, and I go 3 millimeters from the margin of the tissue, and then 3 millimeters on the palatal. And what that does is it relieves tension. You get a double grab in the same site, okay? Now, if you remember last week, I showed you an anterior case. I wouldn't do that if I was worried about the papillar and aesthetic zone where I don't want the tissue to migrate, apically. So for that, I might use a vertical mattress. Again, this course isn't really, this lecture is not really for suturing, but just some thoughts about that, okay? You'll notice the implant got placed. There's a bit of bone apically on that as well. And so there's another example. This was a huge grafting case, and all I used was double simple interrupted sutures. You'll notice the knots are not on the incision line. You'll also notice that the tails are long. Okay, so those are some important things to make note of when you're suturing, to just pull things right over so that they're not sitting on the top. Okay, this is an example of a running continuous suture, okay, for a single incision harvest technique. So you can do a running continuous. One thing I want to point out, and again, it cost me $5,000 to learn this, is something called an oblique suture. Okay, an oblique suture basically is where your free flap is. You can see this is the free flap, okay, the free flap on the buccal. If you start apical, okay, so if you take your needle and you start apical on the mobile tissue, and you go to your fixed tissue and you end coronal. So you'll see it leaves something like this, apical and coronal. When you tie that, this tissue that's here is going to want to pull towards the coronal aspect. So entrance point always goes closer to your exit point. So if I want to make sure things stay, coronal, then I'll start my incision, I'll start my grab apical, and I'll end it coronal. I hope that makes sense, okay? This is a compression suture, again, just some cross mattresses. So there's all different kinds of horizontal mattress for large grafting cases, again, where we want aversion, and then some single interrupted in between. Again, this is just a mishmash of me trying to show off. Again, these are mattress sutures, periosteal stabilizing sutures that go both vertically and horizontally to just push a free gingival graft to the recipient bed. Okay, but a couple key important things that you should just be aware of. Number one, the sutures need to be reapproximated. So when you suture, the flaps need to be reapproximated. Okay, so sometimes I see doctors, and I used to do this too, where we're like pulling things, we're making things so tight, right? I agree, the knots need to be tight, but the sutures itself, the flaps don't need to be tight. They can't be tight. Because what's going to happen? You're going to get swelling. And who's going to win? You or God, right? God's going to win every time. So you got to make sure that when you release things properly, and you follow the steps properly, and you just reapproximate the tissues, okay, that when things swell, they'll happen here, not here. I hope that makes sense. Okay, so if you can release a flap, if you can stabilize your bone, and it's passive, then there's no need to over tighten things. You don't need to over tighten things. Okay, you just need to reapproximate everything. All right, and I think I can't stress that enough. So the final step is compression. Okay, compression is important because it removes blood from pooling. So I would compress at the apical portion, and I'd push. I also want to push my bone coronally because that's where we want our bone. We want to remove any dead space. It also minimizes swelling. So in case there's any blood pooling, you're going to see blood coming out of your incision line, and that's good. We don't want that stuff pooling inside the site. Okay, it minimizes bruising as well. And again, after all of this, rinse your site out so you can just look at the masterpiece that you've created on the patient and take a final photo of that. It should look nice. It should look clean. You should be able to just say, wow, this looks good. And don't worry if some of the tissue is covering the healing abutment. It doesn't matter. If you've release your tissue enough, it's just going to migrate apically. Some doctors say, oh my God, I covered my healing, but it's okay. And I'll show you the case. Now, the final step, which is the 12.5. This is an important step. Assume that everything that you did was wrong. Okay? Assume that somebody else did the surgery and you're just stepping in there to have a look. So clear your mind and say, okay, I take a wet gauze like I do when I do basic, the basic training program, I take a wet gauze, I rinse everything off, I just dry everything off, I push the bone a little bit and I look at it. And now what do? I take a probe, I go under every single suture and I lift up. And if I can do this to every single one of the sutures, well, guess what? God's gonna do that too. So we need to redo the sutures. Okay, or additional sutures required. I still will use some periacryl depending on the case, but I keep it away from incision lines. So I'll keep it maybe around CEJ areas, a little drop here or there just to kind of give some pinpoint areas. But again, the concern with periacryl is you get embedded and then you can get a foreign body reaction. So use it sparingly. Okay. But testing your site, because this is your last chance, guys. This is your final exam. This is your last chance to look at the site before it leaves. I don't care if it's a single case or a full arch case. Step 12.5 has to happen. Okay? It's your final chance to look. It should be nice and clean, and all your sutures should be nice and reapproximated, and your knots should be tight. Okay? And if you're concerned, do it at this stage. Okay? So here's an example, again, a single site harvest of palatal tissue, and we're compressing the site with these sutures. And some would say, okay, that's enough. Well, for me, I only can write the test once, right? So I'm gonna throw some periacryl on top of here, and the patient's also gonna leave with the surgical stent. Why? Because I don't wanna get a call for bleeding from a connective tissue grafting, right? So why are we not doing that? Do whatever you can to optimize the patient, right? So here's a case again, anterior, good periosteal release. We have some periosteum left at the base. We grafted, we sutured the case. Here's an anterior case again, same situation. Again, this was a double, so it's a little bit harder to suture. So let's go through this example. So this is the sutured case, right? So this is at time of surgery, okay? And we could have put a tooth on here, the patient opted not to because of cost. So that's what it looks like. So that's your first picture, folks. That's what you need to take every case. Your second picture needs to be at 1 week. So that's what it looks like at 1 week. So I can see, okay, how does everything look? Oh, maybe that knot, maybe I could have moved it over a little bit, this and that. Okay, there's a 3-week case. Okay, and again, this has monocryl, so I don't have to worry about taking out these sutures. They're gonna resorb. But there's no plaque, right? You can see there's no plaque at 1 week. 3 week looks good. Now at 6 weeks, sutures came out. Things look pretty good. Okay, and then there's the 4-month post-op check. So these are the photos that I would like to see every person at least get, right? And then there's the 4-month post-op CBCT. This case, obviously, we grafted the anterior. So if it looks good, okay, that looks good. I think that looks pretty good. That's nice, it's clean. Things look like they're reapproximated well, then it's gonna heal fine. That's 4 months post-op, okay? But if it looks like a bit of a hot mess, and this was one of my first anterior, mandibular anterior grafting cases, this was a disaster, I'll tell you. This periacryl here on the lower right, on the patient's lower left, canine got embedded into soft tissue. I saw her like 4 times for post-ops. The graft site opened up, but thankfully with adequate management, the case still healed and it was still restored. Okay, so putting this all together now, going back to, and her name is Michelle, Michelle's case of the 1-4. So we have the case. We have good pictures of the soft tissue first in the occlusion. That's the first thing, not the CBCT. What am I gonna do? How am I gonna access this? Now I look at the 2-dimensional, then I review the CT and say, wow, there's really not a lot of bone here. There's some usable bone here. I can get some pretty good crestal bone, but we're gonna be deficient mid-buccal and apical as well. We're gonna need to do some sinus lifting, okay? So now we design our flap. Okay, and sorry, I'm not the best artist here, but my flap design includes, I want a little bit more access mesial, and then I really need to see the site so I can graft, because the grafting has to happen where? Mid-buccal. It's not just at the crest, so I need more access here, right? Okay, so there's now my flap. Okay, crest looks really good. Everything is adequately reflected. Okay, and now retracted. Now we're focusing on our, let me just pull up our steps here. I should probably memorize these. Debridement, so we're going to remove all these soft tissue tags. We're going to debride everything. Now we're preparing our osteotomy, okay? And now once our osteotomy is prepared, we're now placing our implant, okay? So we prepped our implant. And now we're going ahead doing our periosteal release, okay? So our periosteal release happens, and then we're bone grafting and membrane placement, okay? And the final step, suturing. Once this is done, right before these two pictures are taken, I'm compressing the site. I'm rinsing everything off, compressing everything, pushing my bone where I want it to be, having a nice look and evaluating where are my sutures, is anything open? I'm pulling up on my sutures to make sure that the knots are not loose. You can see that oblique suture. It goes from the apex to, again, apical to coronal, okay? And that's what it looks like. There's the 1 week. Remember I said we want to get the 1 week post-op? Uh-oh, the soft tissue is covering the healing abutment. Who cares, right? Leave it alone. There's the 3 week. Already at 3 weeks, looks better. There's a bit of plaque and debridement. So, a plaque. So we would debride that very well. Here's the 6 week. Again, healing uneventfully, looks good. Take a PA at 6 weeks, looks good. We've got some bone graft at the apex as well. And now here's our 5 month. For these larger cases, I typically tend to wait up an extra month, about 5 months. Great soft tissue. And then here is the post-op CBCT, just to confirm the grafting. You can see there's some graft in the actual sinus region, and there's a little bit of bone on the buccal here. I think we'll be okay. So, so now she's ready to go see her doctor, the referral, to do the final restoration. Okay, so let's just go through a few case examples. I think just taking a range of cases, not too many, but enough to kind of just drive the point home. And some of these cases hopefully will be similar to what you will be working on. So again, some of these cases, the ones that I'm showing you here, we've kind of documented and reviewed at our last webinar, which are cases with large defects. So here's Caesar. Okay, so Caesar, he lives in Florida, comes up every so often. He's got a massive infection on the 3637. And so we have to remove these. Believe it or not, I actually offered him immediates, which I typically always tend to do. But he opted for a delayed approach. So I said, that's fine. So we grafted that. So that was a combination of allo-xeno mix with PRF. And then we covered that up with some membranes. I believe I used PTFE membrane here as well, and then a collagen membrane as well. So this is the post-op of the site that healed. Okay, and so how do you manage this case? You got a patient now fully grafted, you're ready to go, 3637. How do we do this, right? So let's go through our steps again. Okay, so we're gonna give our patient really good local, make sure we got good buccal anesthesia, because that's where it's gonna come out first. Now we have a nice, clean flap design. We have multiple 15 blades and a 12C blade, okay, to make sure that we have making a nice clean cut. And we're exposing full periosteum, okay? We're starting at the corners first, and we're reflecting the flap properly, and then we'll go ahead and retract. Once we retract and we debride everything, make sure there's no tissue tags left, make sure everything looks good, then we'll go ahead and use guide pins to place our implant. We can take a PA, we can get the patient to bite down to make sure that we're in proper spacing and 3D orientation for the occlusion as well, to make sure the patient's gonna get full function. And now we're placing our implants to the proper depth to create proper emergence profile. For molars, I like them a little bit deeper. As a result, I'll have to trough the bone. Okay, so you can see here we've troughed the bone, okay, around to accommodate the healing abutments. And the nice thing with the Hyosin system also is you can measure the healing abutment height. They have a tool that they use, like a depth gauge almost, that measures right to the level of the soft tissue. And it's standardized to the healing abutments. And then you just pretty much pick one higher, because you want your healing abutment to be 1 millimeter higher than the tissue. Okay, so we placed our implants, and now we go ahead and we place our healing abutments. And I chose 7 millimeter wide healing abutments. Like, how amazing is that, right? What kind of emergence are we gonna get? Like I said, 1 step, 1 surgery, right? These are double, simple, interrupted sutures. That's it, okay? So they go through the buccal a bit deeper, and then you just come back around and go through a little bit you know, maybe not as deep, and then you tie off and make sure all your knots are on the buccal. And this is using the monocryl, okay, because we didn't have to do any major grafting, so I decided to use monocryl. But you could use whatever you want here at this point, okay? So there are the healing abutments. Again, you can see they're well seated, okay, and you got to check, make sure you know your system. And there's the 2-week post-op, okay? So I'd remove the sutures at 2 weeks because the patient was wanting them removed, and 2 weeks is more than enough. There is the 6-week, and this is taken with my mouthwatch camera, okay? And then there's the 4-month post-op. So this patient, now look at the soft tissue that we got just from the day of surgery. Again, having a system that has these amazing healing abutments or variation really helps. Okay, so that's kind of like a straightforward standard case. Now we take it up a little bit. You know, now we have Michelle here, another Michelle. Actually, I think the first patient, her name was Janice, but another Michelle who basically has a bridge that's failed. You know, and we need to remove the 1-4. The 1-5 has been edentulous for quite some time. So we take some, you know, pictures. We look at the CBCT and we notice that there's very little bone here. Okay, it's very little bone, very little space interproximally as well for 2 implants. You know, it's kind of like one of those areas where it's not big enough for 1 implant. It's not small enough for 1 implant, but it's, you know, it's tight for 2. And so we discussed things with the patient. She opted for 2, but also there's only 3 millimeters of bone here, maybe 4 at the max as far as width. So are we going to need to graft this case? Absolutely. Are we going to need access to this case? To this case for grafting? Absolutely. So I know that I'm going to need to open up a larger flap. Okay, so let's follow the steps again. Adequate local anesthesia. We section, we do create guiding planes. All that stuff is done before we go ahead and open up the flap. Okay, so again, we're following the system. We then go ahead and open the tooth. You can remove the tooth if you wish at that point, but I like to open the site first. Okay, and adequately retract and reflect. So reflect and retract. Now we extract the tooth. And now I have my initial, I'm onto the implant placement site. Okay, now I'm placing my implants in the optimal position, and these are done freehand. You can notice how thin the bone is here on the buccal. Okay, so remember LA, gave some local. We designed our flap. I included 1 vertical, just like I did the first case. We reflected properly. We've now retracted, we've debrided. Look how clean that bone looks on the buccal, okay? Now we placed our implants, all right? And now I've already done my periosteal release because my implants are in. I'm doing my periosteal release and then go ahead and graft. And the easiest way to do it is using my healing abutments to stabilize the membrane, okay? You can see I've closed the site with double simple interrupted sutures, and I put a little bit of periacryl just along the mesial edge, maybe a little bit around the CEJ of the canine just to help kind of rinse and seal that. Again, you'll notice this design of the flap with this vertical, it's just very easy to tie this together. Okay, back. All right, tie it back together. All right, so that's what the finished case looks like. There are the 2 implants. Again, those are placed freehand. Okay, and now we've got the 2-week post-op healing. All right, looks pretty good. Okay, there's the 6-week post-op healing. Again, heals nice. Still the healing abutment's covered, but again, I wouldn't worry about that too much. And then there's the 4-month. Okay, and the 4-month looks great. And that's the post-op CBCT at 4 months. There was actually some, I guess, radiopaque material that was left in the flap. I didn't notice, but I mean, that's the bone grafting that we were able to achieve. And as I mentioned, through proper flap design, periosteal release, following those steps, I do every single case the exact same way, and I'm getting those predictable results. So some say, you know, that these are outlier cases. I've got over 450 cases done, pretty much virtually identical, documented, and they all are showing very similar results. And I think it's because of a system and a protocol. And you can develop yours. I'm all about not reinventing the wheel, but I hope that the system can help your cases as well. So now let's go to a case where, you know, we have a patient who basically presents with, multiple sites, right? So this patient has the upper left site, the 2 premolar sites, a premolar and a molar. So the 2-5 and the 2-6 sites are deficient. The 2-5 actually was removed because there was a large infection, as you can see. Sorry, this should be the 2-5 actually. Okay, maybe I might be wrong. It might be the 2-4, 2-5. Okay, this is the 4-4. So the patient's also missing teeth in the lower right area. Okay, quad 4. So she wants implants 4-4, 4-5, and 4-6, and you can see how thin that bone is. And now we're getting close to the mental foramen, and again, very deficient in these areas. So how do we manage this, right? So first step, we take photos, okay? We assess the soft tissue. What's the soft tissue? What do I need to do with the soft tissue to improve the soft tissue at the time of surgery, if possible? Okay, and this is the treatment plan. This is what we want to do. All right, now remember, the 2-4, okay, was recently extracted, maybe a couple of weeks, and the 2-5 is missing. It's been missing for quite some time, as have been the lower right implants. So let's go through the steps again. Okay, so adequate local. So I like to take one surgical site at a time. So adequate local, same flap design like I showed you, right? See that base of the papilla? I love it. Just gives me so much better access. Okay, now, am I worried about this bone loss on the canine? Yes. So this is where when we suture things back, those of you who feel comfortable doing a sling suture would really help to reposition that tissue and keep it there more coronally. And again, I'm not going through suturing today. Okay, so here's the site that's deficient. As I mentioned, the 2-5, the 2-4 had a buccal defect and a large infection. But here are my initial osteotomies. And you'll notice when I take a PA, that 2-4 is too close. So what I did here now is use a Lindemann. A Lindemann is a side cut drill, and I've moved that 2-4 a little bit distally. And that's the purpose of a guide pin, is to show you that, okay? And now we'll go ahead and we'll place our implants in the optimal position. Who cares where there's bone and where there isn't? Let's put them in the right spot. And at this point, you can see I've used 15 by 20, no, sorry, I think this is a 20 by 30, but one of the healing abutments kind of got cut off a little bit, but that's okay. All you need is maybe one healing abutment, or sometimes the healing abutment can kind of stabilize or just kind of compress the membrane in some spots. So there's the membrane there, okay? And remember, we've already done our periosteal release. That's done. We've compressed. There's no bleeding. See how clean these pictures look? Now we put autogenous bone. We put our sticky bone, fold our membrane, put our PRF membranes, and then we suture this back up. And look, the tissues, like some of the tissues covering one of those healing abutments, that's okay. These are double, simple, interrupted with good knots and reapproximated tissue, okay? Nothing's tight, all right? Everything's just reapproximated. Okay, so there's a 10-day post-op. Now we've got, so let's call it 2 weeks. This is the 3-week post-op, the 6-week post-op there. And there's the photo of the 6 weeks, okay? And then there is the 6-week healing, and we'll see her back. Well, I'll show you the picture at 4 months, or 5 months, sorry. What about the lower right case, right? The flap design I really like is a distal buccal release, okay? That really helps to open this area because you don't want to get into doing verticals in the foramen area if you can avoid it. Now you'll notice the flap has been reflected until I can feel the mental foramen. And now what I'm doing is I'm releasing above the foramen. So you can see this is this is where the dissection starts. And again, I like to use certain instruments, but you can, depending on those people who are advanced, can do it a bit differently. But we've released the tissue on top of the neurovascular bundle. And now you can see when I pull that, I can literally, I could keep going. I could pull this thing right over to the quad 3 if I want. Okay, so those of you, again, who feel comfortable can also do lingual release. Again, that's more of an advanced technique, but I didn't feel like it was required here, although we could do that, and that's Rossetti's technique. So now we do our implant, placement. Again, we're just prepping our osteotomies using our guide pins, checking the occlusion, and then using a PA. And again, it's important to know the measurements on your guide pins, so you need to know what you're looking at. All right, so there are the sites we've now placed, and again, different people would do it different ways, whether you ridge split here. For me, I like to place the implants and then, just use the healing abutments, again, to stabilize the bone graft, okay? And you'll notice decortication here should have been done before the implants were placed, okay? So I didn't listen to my own steps, so that's just a point that I wanted to point out. And now we can add our bone. There's our lovely sticky bone. It's just like a putty, just sticks there, and then we fold it over, put some PRF membranes, and because we've released everything, this just closes back fairly easily. Okay, reapproximates. Again, it doesn't need to be completely closed. I've got PRF and approximate there, and now we just let that heal, right? So there's a 10-day post-op healing, and then there is the 3-week post-op healing, and then here is the 6-week, and you can see here there's a bit of cytoplast suture left, they are hard to take out in mucosa. You know, now I would have used monocryl. But you know, those of you who've used a cytoplast and tried to take them out in these series, it's not easy. You got to freeze a patient. So here's a 4-month post-op check. You can see, again, the soft tissue, the bone. There's the bone grafting in both sites. Again, has taken very well, and it's just going to mature moving past that. And then there is the 4-month post-op check for the lower right. And again, you'll notice here, there's significant bone grafting that's now filling that buccal defect. Okay, locator case. Many of you are doing locators. So this is, as I mentioned, the best way to do it is to have a good flap design to make your life easier. So having or creating a tear mid-buccal, or creating an incision, I should say, not a tear, but an actual controlled tear, I call it, in the buccal will help you to reflect, because the only way you can access mental foramen is by reflecting anteriorly. The more you reflect anteriorly, the easier it is to have access to the mental foramen. So what I like to do is, again, these cases, the foramen is on the ridge, so I don't necessarily go and expose the foramen. I like to do initial trial guide pin. You'll see the guide pins are anterior to the foramen. You can also have a loop, so I like to stick generally from, you know, I like to stick to the canine, or maybe first canine region, and then take a PA and see where you're at. So when I take my PA, I generally kind of fire it to the PA and distal. You can see the foramen really nicely here. And you can also see with the guide pin how wide my implant or my osteotomy is going to be. And this is one thing I love about the Hyoscine guide pins. They're 4 and 5. So I can already see, once I widen my osteotomy, where it's going to end up. So I like these positions. So I place the implants there. And then this was going to be a fixed case. So we actually wanted 5 implants here. So again, I just make my initial holes. Our implants get placed subcrustally. And remember, this is like everything's D1 bone here. So if you're placing a 4mm implant, you have to prep to 4.5 to get these down. Okay. And look how clean the site looks, right? That debridement step is so key, because I'm not worried now of any tissue getting in around implants or anything. PRF goes on top, and then I suture that right back up. Okay. And it's nice, it's clean, and then we let that heal. Okay. I believe this is the final case, which is an all-on case. I know some of you are doing all-on cases. So how do we manage those? And I can tell you, I got approached a while ago, early in my career, I should say, to do these cases, and I actually declined because I just was not surgically ready. But you have to be ready to do these cases surgically. You have to have enough experience, and especially in cases where there's significant amount of deficient bone. And so you can see in the 2-3 site, you don't have to go to Kumon to know that if there's 4mm of bone there and you're placing a 4mm implant, it ain't going to work. Or you got to figure out how is it going to work. Okay, so these cases are a bit more challenging, again, depending on the case. But what's important to note is adequate reflection, and again, and good retraction. I think those are key. Local for these cases. So let's start off the steps, right? Local, you have to make sure local is apical to where your flap is. Even if these patients are sedated, still local is important, right? To maintain their blood pressure. Flap design is important as well. You need to have adequate access to see everything, really, right? And to be able to seat some of the guides, especially if you're doing guided. I mean, you really need to have good access. Your incisions have to be clean. You know, when you reflect, you want to get full periosteum. Oftentimes there's a lot of infected sites. You want to make sure you keep the infection on the bone so you can remove it. Retraction, you want to have good retraction. Oftentimes if you lift the flap well enough, then retraction will happen kind of on its own. Debridement, when we're placing our implants or doing our debridement, or under the debridement section, our alveoplasty, using good guides. So this is just, you know, a prosthetic guide. You can see the dentures here. We've got 15mm trimmed, so I know exactly how much bone I need to remove. This case, just to throw things in the loop, had a fairly high sinus, meaning the sinus, I guess, came fairly far anteriorly and was going to interfere in where I wanted to place my posterior implant. And of course, our aim is to give the patient the best AP spread. So as I started doing my reduction, I actually exposed the sinus floor from the crest. So we did, I guess, a lateral sinus lift, but we did it crestally. So once I lifted the sinus, and I lifted it right to the medial wall and fully anteriorly, now I just treat this like almost like a zygomatic case. I make my osteotomies, and again, I had to do this on both sides. You can see the sinus floor was elevated crustally but directly, I guess you could say, right, on both sides. Now what I'm doing is I'm aiming for that hard bone, that anterior wall of the sinus and the floor of the nose. That's what I'm looking for. You can see the trajectory of the drills, and that's exactly where I want my implants. And I'm telling you, when you get into cortical bone, you get no stability, and all of a sudden you get 100 Newton stability on these implants if you can really engage those areas. So you'll see 80% of that implant is floating in the sinus, and probably a good 3 millimeters is engaged in cortical bone. No different than a zygomatic implant, okay? Except we're doing it using the alveolar ridge. So once the posterior implants are placed, and you'll notice troughing, right? Remember I said debridement, troughing around? You need to do that in order to seat the multi-unit abutments, right? So that's part of my protocol. Then I use Alan Simon-Pierre's protocol, where he puts this into the nasopalatine foramen, just using it as a guide to place the implants, just to get parallelism. We have a cutout on the template to tell us our angulation on where we want our exit points or access points to come out through the temporary prosthetic. And then we're placing our implants, okay? And in this case, because there were so many teeth that needed to be removed, by the time you remove the teeth, okay, and you drill holes for implants, there's holes everywhere. The buccal plate started to fracture. Yeah, welcome to my life. So for this case, we actually had to use screws and tacks to stabilize the bone, grafting, and the bone that had fractured. And collecting autogenous bone, this is just a autogenous bone collector that runs through the suction line. You can get this and get a ton of autogenous bone, which I like to have on the threads. But the key here was we were also into the nasal floor. So for this case, we actually did some nasal floor lifting, and this is the patient's nose. So very similar to the posterior sinus, because we had a deficient bone in the anterior maxilla. So we wanted to do some implants in those areas, and then also not perforate, obviously, through the nasal mucosa. One little trick when you're suturing is that if you have enough palatal tissue, you can actually tissue punch and then run that over the healing abutment, and it gives you more keratinized tissue on the buccal. And then you suture the buccal tissue to that, and that buccal tissue just gets apically positioned. Okay, so again, I might be going through a little bit too much, but this is the case. You can see we put collagen membranes to cover the sinus lifts using the healing abutments. I've got PRF covering the entire site, and then it's sutured, and it looks beautiful. I'm happy with that. The lower wasn't as challenging, so we did implants on the lower, and the patient left with teeth screwed in. This is the teeth in a day, all on, whatever you want to call it. That's what the case looked like. You can tell one implant, actually, we didn't get stability because the buccal plate had fractured, and we created too many holes in one site. So it was a lesson learned for me. But you'll notice I did additional sinus lifting and bone grafting in those sites in anticipation of potentially adding more implants in the posterior in case we get an issue with the angled implants. Okay, so that's the that's the 3-week post-op. So things actually is healing very well. And those are the temporary prosthetics that you can see on the lower. And then we have his 3-month post-op. So we're going to let him heal for 6 months. But the 3-month, everything is healing really well. Everything is stable. And then these are the PAs. You'll notice that there's a significant amount of bone grafting on both sides. Sorry, got cut off on the left. So follow the steps. You know, if you follow the steps, you can achieve. You know, you can achieve whatever you want. But again, everything depends on your expertise. And these steps can be applied to basic surgery all the way up to advanced techniques. But having a protocol to me is super important. So, you know, ultimately, I'd like to, you know, I hope what we went through is beneficial. Make sure that you do, you know, visit our Facebook and our Instagram page. And if you're not a member, as I mentioned, we are offering people, you know, complimentary membership just for our group chat. We'd be happy to have you guys on board. Also, as I mentioned, there's a sinus course that is coming up on the CAS kit for those who are interested on Thursday, and that's through AIC Education. Hisham had already mentioned that we do have some great courses coming up, and I would highly recommend you, you know, checking them out. Great speakers and great topics, and I'm excited actually to be a part of them. So I'd like to thank all of you for your attention. I hope things were beneficial. And I'd pass it over to Hisham.
All right, perfect.
And
So wanted to thank you. And I'm Hisham.
let me stop sharing my screen here. Here we go.
Am I still there?
Yeah, you're good to go, Manisha. We can see you.
Okay, you can see me. Okay, I've just lost the video there, but that's fine. So thank you so much, Hisham, Azim. That was amazing, as always. It's not easy to talk for 2 hours straight, and appreciate your awesome, detailed advice on how to move forward with some of these cases. So just a reminder for tomorrow's lecture, 12 o'clock with Dr. Kevana Bazadeh. I'll be talking about orthognathic surgery. Remember, the password is Amity20, all in capitals, and the number 20 to log in. We're going to have that password for all remaining talks, just to keep everything private for our group. To register for this and for other talks, you can go to dtacademy.ca/webinars. So again, that's dtacademy.ca/webinars to register for this and all the future talks. You will get emails on this as well as we move forward. You can also check out all our past lectures on Dentistry Disrupted. The majority of lectures will be uploaded onto that site. And so that's Dentistry Disrupted on YouTube. For CE, remember to please type in your email and your name into the chat. If you are unsure on how to do this, don't leave yet. Just unmute your microphone and ask us, and we will be happy to help you get that organized, because maybe we'll actually show everyone, just in case there is any confusion on that. That way you will be a part of our official log, and you can use the certificate that will be sent out to you. So we will, without further ado, open up our question and answer period, and we'll start with Waqar Ahmed. If you can go ahead and ask your question directly, remember to unmute your microphone and go ahead and ask Dr. Azim straight up.
So first off, thank you, Azim. That was very beneficial. And also thank you, Manisha and Hisham, for organizing this. I just had a quick question about, I think it was step 4, where you mentioned reflection. Mm-hmm. So when you're reflecting in sort of a diseased area, and you mentioned that it has to be sort of a split thickness. Let's say there's a fistula or a communication. How can you avoid perforating through?
Yeah, so that's a good question. So what I like to do is I still like to do my regular split thickness flap, okay? And the fistula is as a result of the reaction to what's there, which is the tooth, which is the infection, right? So depending on the size of the fistula, okay, if it's a fully open area, then what I would do is once I get to suturing my flap back, I actually will take a suture, like a small needle, like a 13 millimeter on a 5/0 thread, like a monocryl, and I would actually close that small little hole up. Most of the time I find you don't have to, especially if I had PRF on the buccal. I find that that just resolves on its own. But you're right, I don't want to rewrite the test, right? So I would suture my flap, and then I would go back in that area and just tie that one little area off. And remember, because there's no infection, there's no source of infection, then that will resolve on its own.
Gotcha. Okay.
Yeah. I hope that helped. Yeah.
Yeah, it was better the second time around.
Sorry, say that again, Waqar?
It was better the second time around. Azim gave this lecture back in October.
Okay, good. Okay, good. I'm glad. Yeah. I kind of threw in some extra stuff today, so I hope it was beneficial. Thanks, Waqar.
Thanks, man.
Thank you so much for that, Waqar. We really appreciate it. The next question comes from, give me one second here, comes from Usman. He asks, and this is early on to Azim, when you had the horizontal incision on the flap that you're reflecting. His question is, does not the horizontal incision cut the blood supply off the papilla?
So it's a good question. The papilla has blood supply from the palatal aspect. And so as long as and again, I wouldn't do this type of incision under a papilla if the papilla was very narrow and very small, or there was a lot of recession in that area and there was really no papilla. So I think that's a great question. If it's a broad papilla and I feel like, you know, I'm going to have something, because remember, the purpose of doing this is to, number one, have access, but to number two, how are you going to close? So if you feel like this is going to make it an easy closure, it's very easy to just close like that, as opposed to grabbing the buccal, then going through the contact, grabbing the papilla, and going back through the contact and tying it off. So I think it's a case-by-case basis, but I oftentimes find the papilla is broad enough for us to do that. And it doesn't cut the blood supply off at all.
All right, and next question is from Shweta Chug, and she is asking if you can share the instrument list again. Wondering if, is this one of the talks that is going to be uploaded onto Dentistry Disrupted? And if so, we can access it there.
Yeah, so what I could do is I could share with you the Dr. Sheikh implant kit, which contains the instruments. And then you can go through whatever provider you want to get them. I mean, you're happy to go through Hartzell, which is owned by Denmat. I know Cytogenics also carries the exact same kit because they came up with that for our basic implant training program. So I'd be happy to share maybe an example of those kits. Perhaps I can send that out. I did plan on sending out a copy of the slides, just the steps, not the whole presentation because it's too big, but the actual steps, like step 1, step 2, step 3. So if I can send out in that same attachment the list of the, a picture of those instruments, then I'll do that as well.
Perfect. And Shweta says thank you.
No problem.
Mm-hmm.
The next question comes from Zishan. He asks how to separate diseased tissue from healthy tissue while raising the flap.
Yeah, so honestly, it's a great question. It comes with experience, but if you think about it, when you raise a regular flap, okay, and you open up that flap and you start pushing on it, it starts peeling with the periosteum, all right? When there's a diseased area, what's gonna happen is you're gonna start lifting the flap and there's gonna be resistance, okay? You're gonna see resistance. And you're gonna notice it's a darker color. Oftentimes it's like a darker red. So what I like to do at that point is I like to take some cotton pliers and I'll take my 15 blade and I won't angle it out towards my flap because I don't want to perforate the flap. I will angle it towards the bone and I'll just start filleting. I'll start filleting it because who cares? Even if there's some healthy tissue, it doesn't really matter. As long as you still have a good 0.5 millimeter to 1 millimeter flap on the outside portion, that'll still provide blood supply and coverage for your grafting. Then that's all you need. But it does come with experience and knowing it. And some doctors say, you know, I'm just going to lift the whole flap and then try to take it off of the flap. But I think you have a higher risk of perforating the flap when you do it that way. So I hope that helps. But it's really feel and going very slowly. And that's why I said the first 4 steps should be done with care and slowly. You're setting yourself up to make things early, to make things easier later on. Because what's the hardest part of surgery? Suturing, always. That's what's going to take you the most time. So if you have a clean flap and you have a clean, you know, something nice to suture back to, that part's easy at that point. Well, easier. Let's put it that way. Yeah.
Okay, awesome. Thank you. Next question is from Kuram Rajput, and he is asking, when do you use EDTA during site prep? Or in other words, what are the indications for EDTA during site prep?
So EDTA is not required, okay? It is if there is an area that I'm working in whereby, and remember, and again, to put things in perspective, most of the cases that I'm dealing with are large infected sites, okay? So for a standard case, EDTA is not in the picture. You don't need it. Some doctors may do it. If you reflect the flap and you see recession, you know, you may want to make sure that the recession doesn't get worse after you suture the case. You may prep the site with EDTA and then use a sling suture to keep things, you know, in position. But I'm using EDTA when the defect is so large that it has affected the neighboring tooth. And in that case, I know my bone graft is going to need to be in that area as well. And I want to make sure that tooth is as clean as possible. And I showed a case last week where I, in fact, after the EDTA, I actually, before I grafted, I packed Emdogain, the Emdogain, which is the enamel matrix protein, on the tooth before I went ahead and packed in the bone grafting. And this is something similar that periodontists do, as I do, for vertical defects around teeth. It's no different. So yeah, so that would be, I hope that answers the question.
The next question is from Omar. He asks, hi, Dr. Sheikh, are there any suturing training courses that you would recommend taking?
That's a great question, because honestly, I feel like there's a huge need. Now, I know that Hisham has been working on a training program with suturing, with videos, and I think that would be probably your best bet. The problem with courses right now is there's so much information packed into a course, and the hands-on, you're learning technique, you're learning this, and the suturing is kind of like an afterthought. Everybody assumes we know how to suture. So I normally do one study club meeting on suturing, and I make it a priority because it's super important. So maybe getting involved with a club or like Hisham's group, Dentistry Academy. You know, I know we do it for Odin, but actually I don't know of any currently right now. I do know Zib Simon offers amazing material on suturing, and he's got books on suturing as well. So learning online might be an option. But I can't specifically tell you of any courses. I almost find that these courses, suture is an afterthought, right? And even if they do discuss it, you don't get a lot of hands-on on actually doing it and performing it. And then it's completely different when you're working on the patient who's bleeding, right? You know, and you can't rotate the pig's head and do all these types of things, right? So I think the key is, you know, learning what you can online or through different venues, and then actually taking it and doing it on a patient on a basic extraction. Do a vertical mattress on a patient. Do it. That's the only way you're going to really get good. Yeah.
Absolutely. And to just add to that, thanks for that, Dr. Sheikh. We did do the full recording for the modules this past weekend with Dr. Tina. So we're just putting something together for everyone about different type of suturing and flap design as well, which would be very, very informative for everyone to use and share.
Great. Excellent. That's awesome.
And anyone that wants to turn on their video, feel free. We'd love to see your face. It makes the discussion a little bit more interesting. So if you feel comfortable doing it, I would love to open that up. And so next question comes from Eric Neves, and he asked Dr. Sheikh, what is the purpose for the periosteal release? Is it always necessary? And is decortication always necessary as well?
So those are all great questions. So the periosteal release, the purpose of the periosteal release is in essence, if you're adding volume, okay, so if you're grafting and now you've added more volume. So remember, your tissue was here, right? And now you've added volume, okay? And now you want that tissue to still come back here. How is it going to do that? It can't go back because now you've added stuff in there. So the purpose of the periosteal release is to release the tissue. Once you release the tissue, it becomes mobile. So you can pull it over and close the same way it did originally, I guess you could say. Does every case need to have it? Most cases that most dentists are doing do not require a periosteal release. Because if you think about it, if you have a site that's edentulous, okay, that's edentulous, and you're creating an incision and you're opening up that site. Now you're placing your implant. Hopefully you are all placing a healing abutment at the same time. That healing abutment, let's call it 5 to 7 millimeters. You've now just gained, now you don't have to close that 5 to 7 millimeters back anymore, right? So you've just gained 5 to 7 millimeters of release, right? So you don't need to actually have a periosteal release. So I always the periosteal release is based on how much volume we're going to add and whether we actually need to do it in the first place, okay? Decortication, some believe it's not required. The purpose of decortication is if it's heavily corticated bone and bone grafting material relies on blood supply to feed it. By decorticating and putting little holes in the cortex, you get these bleeding points that then feeds your bone graft. So I like to do it in the lower arch for sure. In the upper arch, depending on the thickness of the bone, I may or may not do it. And I personally have found it doesn't make a difference with my bone quality, as many people would agree. So it's the purpose of it is to give your bone better blood supply, but then is it really required? Some would argue it's not, some would argue it is. I think it just looks really cool on a picture, but it's an added step that may not be required. Okay, so yeah, I hope that answers that.
Another question about decorticating, Azim. Do you, when you go ahead and now, what kind of burr do you use? Also a diamond?
No, so there is a really nice burr made. You can order this from Surgical Room. It's made by Meisinger, and it's actually called, I think it's called a decortication burr. And it's like, it literally, it goes into your, you know, your surgical handpiece. So it's got a latch type, and it has a 2mm stopper on it. And literally you just push as hard as you want and it perforates through the cortical bone really, really nicely. So you don't really have to worry about going too deep or anything like that. You can even actually collect bone with it too, right? So you can use it at slow speed, perforate, collect the bone, and then rinse and irrigate afterwards. I like to do that too.
Awesome, thank you. The next question is from Pat. He asks, which collagen membrane does Urban use and which one is available in Canada?
So Urban uses the BioGuide, which is basically from Geislich, right? That's his main go-to membrane. It is a, you know, in essence, it's an expensive membrane. Okay, it's a more expensive membrane. It's a native collagen membrane, and it's very nice to use. I don't use a lot of those because I'm getting very good results with RTM collagen. And that's a collagen membrane as well, but it's not native, it's cross-linked. So native collagen basically means that it hasn't been processed like a cross-linked collagen. Native allows you to drape and allows you to manipulate the membrane much easier, but they cost a lot more than native collagens. But that's typically what people would use for the sausage is a native collagen. All of the native collagen membranes that are available, they're all available here. You can get it from Geislich, or Handsome Med, I think is who sells it. You can get other versions of that, like you know, a Neomem Flex Plus from Cytogenics. I know Surgical Room also sells their version of a native collagen membrane. They're all very readily available. I like to keep my stock very simple. I just have my Cytoplast, which is my RTM collagen. And then I have my Neomem Flex Plus, which is my native collagen that I use.
Thank you.
Great. Next question from Vijay Singh. Can you please elaborate on post-op instructions?
No.
Okay.
So post-op instructions are very simple. We scare the hell out of the patient because I show them typically those who want to see the post-surgical picture. Okay, and I tell them where it is right now is where I need it to stay. Everything past this point is based on you at this point. So the instructions are don't pull, don't touch, don't breathe on it, don't look at it funny. You know, we've added volume. Anything you do to smile, if you smile really big or you pull or you send me a picture, my pictures are going to be a lot better than your pictures. You're welcome to all the pictures. They're typically on antibiotics. So they normally start about a day before and a full week course. Because again, most of these are larger grafting cases with infections. They're also on, I typically give them Tylenol 2s, and then they use that in combination with ibuprofen. And then generally we give Paradex, alcohol-free, but they don't use that for 2 days until 2 days after the surgery. So nothing for 24 hours, no rinsing, anything like that. And then after 24 hours, they can use warm salt water. And then after 2 days post-surgery, or even 3, then they can start using the Paradex rinse. But oftentimes, most patients are just using salt water. That's it. Half a teaspoon of salt, warm cup of water. And then they get my phone number. We do a care call the next day. And then I always see them back. If it's a larger case, I see them back in 1 week and 3 weeks. And then my regular 6 week and 4 months. If it's a routine case, I'll see them back at 2 weeks. And then my 6 week, 4 month.
The next question is from Nazia. She asks, why don't you do the periosteal incision at the time of the regular incision? Can you please clarify?
So that's a great question. The reason I don't do my periosteal right away is in case, because once you do a periosteal, you've now committed to where that periosteal is. So in case I didn't reflect enough initially, if you do a periosteal, now that periosteal is not part of your flap anymore. It's on the bone. So it's crucial to not do the periosteal release at the beginning, because if you need to backtrack, you can't backtrack past that. It's an error that's very hard to correct. So it allows me more flexibility during the surgery in case I decide, oh, you know what? I have a perforation for my implant, and guess what? It's even higher up than I thought it was going to be. Then I can reflect my flap higher and then do my periosteal release from that point. Okay?
Yep. Sounds good. Next question is from Bo. Where do you get your resorbable sutures from?
So I order them through Ethicon. And basically, normally, again, part of our study club, we do like a group discount and we buy in bulk. And so I get all my, Cytoplast you can't get, you have to get through a separate provider. But most of the sutures like monocryl, vicryl, chromic gut, we just buy that stuff in bulk. And so I get it through Ethicon, which is basically, Johnson & Johnson. And that is a deal done through Surgical Room. Yeah.
The next question is from DS, and the question is, for all on-X cases, do you think 4 implants would have been a better option looking at the amount of osteotomies you have to do in the upper arch? Yeah,
so it's you're right. It is a trade-off, but the problem is when you've done enough all-on-4s, you realize that you shouldn't be doing all-on-4s. You should be doing all-on-X, which is all-on whatever, right? So I prefer 6 implants for an upper, and I'll even do 6 for the lower. But it does come with a risk, because if you think about a socket, if you have multiple sockets lined up, and then our implants typically are placed in the sweet zone, which is if you have a socket like this and a socket like this next to it, you see this little triangular area right there? Palatally, that triangle right here, that's where we like to go. So now you got a hole here, and a hole here, and that the buccal plate literally, and when I started seeing that thing crack, I'm like, oh, great. So yes, 4 could be enough, but I'm still going to be in this business long enough to see patients 10, 15, 20 years down the road. I only want to do this once, right? Ideally, if I can. So 6 implants would be preferred, in my opinion.
So Azim, just to add on to that, so what happens in a scenario like that if you're using that bone and all of a sudden you're placing your implant and then the buccal plate starts to crack off? Do you remove the buccal plate and just graft it, or do you go ahead and keep it, or does it depend on the size of the fracture of the buccal plate?
So it depends on where the fracture is coming from. Oftentimes, it will fracture as you're placing the implant. Mm-hmm. So as you're placing the implant, and you have to think, like, where is the tension? Where is this stress coming from? So if you're using a tapered implant, it's coming from the crest of the implant. So what I'll oftentimes do, and what I did in Andre's case, the case that you saw, was I backed out the implant, I reapproximated the buccal plate, okay? And then I troughed out the crest portion, and I placed the implant, and I didn't get primary stability, which is why there was a cover screw on that implant. So I'm relieving the tension where I feel that tension is causing the buccal plate to come from. Because if you remove, and that buccal plate, that would have literally taken the buccal plate from the mid-anterior nasal spine right over to the first premolar, there's 0 bone there, right? Like at that point, I'd have to go and harvest ramus, with my cube or my piezo. And, it can be done, but I think reapproximation and being mindful while you're placing it and watching things, and that's why it's important to have good reflection, right? So you can see these things going on. If there's a crack, it's okay. And we do ridge splits all the time and they heal, right? So there's nothing wrong with a crack, but if it's free floating and it's not reapproximated, that's when it becomes a problem.
Thank you.
Great. Next question is from Michael Ma. Does everybody get antibiotics after implant placement, or are you selective?
So I'm trying to follow our college guidelines as closely as we can for no antibiotics for simple cases. But if there's bone grafting involved, then I will almost always use antibiotics in conjunction with the surgery. Now that antibiotic usage, again, depending on the case and the patient, maybe something as simple as just a loading dose before, or it may go right up to a full week supply. And I think it's a case-by-case basis, depending on their medical, depending on, you know, the patient themselves, their oral hygiene, you know, are they traveling, are they not traveling? There's different considerations there, but it is a case-by-case basis. I couldn't say standardized, we always give every patient antibiotics. No, that would not be the case.
Great.
Now, adding to that question, Melvin asks, what is your policy on patients having complicated medical histories, let's say on bisphosphonate therapy?
Yeah, so bisphosphonate, in essence, is not, I mean, it's not a contraindication. It's a relative contraindication. It's not an absolute contraindication to treatment. I would inform them of the risk, but again, there's no real solid literature showing that a patient who's on oral bisphosphonates will have bisphosphonate-related osteonecrosis. So I give them, in my consent form, and I tell them, I say, listen, there is a risk. One of the things that really has helped to circumvent this, and this is not just from myself, but just generally in the implant community, for those of us who are placing many implants, is platelet-rich fibrin. PRF has really helped to mitigate the issues with, you know, bisphosphonate-related osteonecrosis. Now, again, is there literature on that? No. But I feel comfortable treating patients on oral bisphosphonates, but I do give them the risk as I do any other risk. If it's IV bisphosphonates, I don't treat them. I refer them out. And again, you have to pick your own battles and you have to determine what case you feel comfortable treating. Some doctors don't want to treat anybody on bisphosphonates, and that's okay. But I think we're held to the standards of what specialists would do. And I think we should stick to those standards and say, do we feel comfortable doing the case overall? And I'll get them to see their family doctor as well if they will have those concerns. You know, the papers that are out there, you can show them that type of stuff. But at the end of the day, it comes down to your comfort and the patient's trust in you and your ability to do the surgery.
Yeah. Awesome. Perfect.
Next question, Ashvik Ahmed asks, he says, first of all, thank you to Azim and the organizers. Question, if during flap reflection, you get a minor tear or two at the free gingival margin, is it appropriate to suture the tear ends with 5.0 or 6.0 monocryl first, prior to reapproximation of the flap with final suturing?
Yes, it is, but the key to that step is not getting them in the first place, right? Because again, then you're suturing hamburger meat back, and then it becomes very difficult. Because what happens is that oftentimes when you do those little mini sutures to try to suture the little pieces of the flap back at the marginal gingiva, then you create other additional holes while you're doing your main suturing. And what happens is if you haven't released the site enough, then you can actually the flap can tear open. And so, because you think you have these tiny little punctures all kind of in the same site, and those tiny punctures can add up to, with swelling, one bigger hole. So the key is to not get those. But if I would get those, I would prefer to suture those first. So have had flaps where I'm lifting the flap and the coronal portion is good, and then I get a nice big tear because, you know, you get that apical concavity. You get this tear in the middle, and then you reflect the rest of the flap. So you have like this big tear in the middle. So I will suture that back first, and then I'll suture my primary flap back.
Great.
The next question is from Kareem Kadri. Kareem, you can go ahead and ask the question.
All right. So thanks, Azim, for the knowledge. It's really, you know, it's very profound. I wanted to ask you about when you're doing your release. So it's funny you said just about 18 months ago you realized that when you're doing the release that you're you figured out the better way to do it is to go right to the vertical release. It's the same thing for me. I just realized maybe within the last 6 months that I wasn't doing them fully. I was just kind of making slits like this.
Exactly. Yeah.
It seems like when you're doing it, that you're going right underneath the flap, like kind of apical to the most, like to the deepest cut into the vestibule. It seems like this.
Yeah.
Whereas I've been going like this. But I'm wondering, is there any benefit to doing it deeper into the flap, like with vascularity, or is it,
It's the amount of release that you're going to get. So if you do what you showed me, which is pretty much still in the flap and not next to the periosteum, then you're really just, what you're doing is you're just splitting your existing flap. That's all you're doing.
Yeah.
You'll still get a bit of release.
Yeah. So what I've been doing is going like this. I've been going like this.
Yeah.
So I've been going to the margins, because before I wasn't, like, maybe not this high up, but a little bit deeper.
Mm-hmm.
But I've been going like kind of like that. The reason I'm asking is because when you're doing the membrane tacking with the sutures, you mentioned that it makes it a little bit more complicated, because then you're fixing something that you would have tried to make a little bit like mobile, right? So once you put this membrane tacking sutures, you can't pull that tissue anymore, right?
Well, this is the purpose. So if you see your flap, your regular flap, if you can imagine the base of that flap, and you're just taking your 15 blade from one side to the next, and you're splitting the tissue in hopes, well, not with the purpose of leaving a band of tissue that's still on the bone. Do you get what I mean? Like leaving a band of tissue, and then that band of tissue, you could actually take your Molt 2.4 and you could undermine that. And now you have like a second minor flap. That's the flap that you're going to use to suture to when you're doing a periosteal stabilizing suture. Right?
Do you find that you said you don't like them as much? So I never used flaps. I just kind of rely on I do the same thing where I kind of tuck my membranes underneath the fixed portion of the flap.
Yep.
And I use that to kind of stabilize it. And I also use a poncho. But I sometimes actually even I moved away from this, but I would tighten down the membrane with the like, instead of putting it and kind of draping it over, I used to tighten it down, because that's how it was taught. But that just kind of makes more problems, because if you don't make the hole big enough, you end up just moving the membrane sideways like this, right? And it kind of twists it down. But I think the better way to drape it over, right? Yeah,
what I like to make the hole for the healing abutment, and then, but that's what I was saying. One of the problems is people don't make it big enough. And then what happens is it gets stuck inside the implant, and now it starts fraying upwards.
Pull it up, so
you have a system like for example, the one I use, Hyacinth, it has wider healing abutments. Then and they're like really nice cone shapes. You can have that membrane sitting higher up, right? So when you tighten it down, now you can literally pack the bone right on the right on the healing abutment. And then as you fold it down, your bone, by the time you fold it down, it's pretty much right at the crest. So all of the CBCTs that you're seeing, and people always ask me, how are you getting all this bone at the crest? It's because I'm using sticky bone and I'm pushing that up. But I agree with you, a periosteal stabilizing suture is not required if you can stabilize your implant and use your healing abutment to drape the membrane. And that's the number one goal for any case that I do, is to do it that way. Periosteal stabilizing sutures are great. I mean, it's showing off, to be honest with you.
Yeah, it is.
It's not easy to do those. And you have to be able to grab the apical tissue, and you have to know how to do it. You know, so some people come from the distal, go mesial, like where do you start palatal? You have to know how to do that, right? And once you learn, you can do it, but it's not easy access, especially for these larger grafting cases where you're going so far apical, right? So
the other thing is that when you're doing the like trimming for the sutures, I also you mentioned Ziv Simon. He's very good. He uses the packing, or actually the pack for the sutures, because it's already sterile, right? He uses that as a template, so you don't mess up your collagen membrane, and you can use it and put it on the site. Say, okay, this is what it's going to look like. You can put it on your site. I use it for like grafting too. So if I do like free gingival grafts, and I need to get how big my donor is going to be, I'll put that on the site, figure out how big it is, trim that, and then I'll put it onto the tissue directly. And then I'll be able to make my incision and everything. I found that was helpful too.
Okay, good. Yeah, that's a great point. Absolutely. No, thanks for
Well,
sharing.
thanks so much. I appreciate it.
No problem. My pleasure.
Thank you so much for that, Kareem. We're going to have one more question by VJ. VJ asks, what is your take on flapless implant placement?
So when I started off my career, everything was flapless. And when I started seeing failed implants, I realized I can't do flapless anymore. So I am, once you start doing more implants, you will quickly realize that flapless is not a good option for 90% of cases. There's a few, 95% of cases. And my practice is referral based, right? So these patients are not my patients. I have a network of maybe like close to 40 offices that refer. So I don't have the luxury of, doing a case and saying, oh, it's okay. I can. So again, it's the mentality of I can only write one exam. I don't want to make sure. And I'll tell you, the largest case, the number one case that I've seen of implant failure, and I've seen it firsthand because I have a group of, many doctors who are sharing their cases, are unknown apical perforations. And you didn't realize there was an apical perforation, you place the implant. And it's typically in premolars, sometimes even anteriors in those concavities, and you don't see them, but they're there, and you may not have felt them, right? And so it's better to see. And the patient wants to do one surgery. So again, I would take flapless surgery with a grain of salt. You have to have a certain case with adequate keratinized tissue, adequate bone, and those are extremely hard to find, in my opinion.
Awesome. Thank you so much. And that wraps up all of the questions. I know that there's a couple more, but unfortunately won't be able to get to them due to timing. If you do want us to answer those questions, please feel free to email us. We'll be more than happy to go ahead and answer it for you guys. Once again, dtacademy.ca/webinars if you choose to sign up for our upcoming courses. We're looking forward to having Dr. Kayvon Abazadeh tomorrow at noon to talk about orthognathic surgery. Once again, Dr. Azim Sheikh, thank you so much for everything. That was very informative. And it's always a pleasure having you.
No, it was my pleasure. Thanks for having me, man.
Awesome.
Both of you, I really appreciate the opportunity, and thanks for all the hard work. I really meant what I said.
Absolutely, our pleasure. And thank you for everything. And thanks everyone for joining us today.
Bye,
Cheers.
guys.
Bye.